Good evening, consultants, fellows on the call, and colleagues. We welcome you to today's meeting, and we are fortunate and blessed tonight to have our presentation today to be led by a very respectable authority in cardiology and interventionist, Professor Oluwase Oladimeji. He has taken time to take us through the intracardiac ECG to help us understand so that we'll be able to answer the questions that come from the EP with respect to the intracardiac ECG. And we are very grateful for this opportunity to listen to Prof. Prof, please, you can hear me. You are welcome, and please, your audience.
Okay, sorry. I want to be sure my screen is showing now.
Prof, please, it's showing. We see EP
showing.
presentation. Yes.
Yes. Okay. Okay, so please kindly let me know if I'm not audible at any time or if my volume is not loud enough.
Yes, sir.
Time. Then number two, if there is any way you are not understanding and you want to make clarifications, please also kindly alert me.
Yes,
Okay.
sir. Yes,
So
sir.
my name is Vladimir Joluwashe Michael. I'm just nicknamed as Prof, but I know the time of being a prof is soon. Okay.
Amen, sir.
So, our main target focus today is actually to make some little discussion about EP. It's not the full lectures yet, but at least we should start with some basics. And the purpose of this basic is so that we can first answer some quick questions because the exam is drawing close. And so it will not be nice to see those EP broad questions in the OSCE station and not be able to attend them properly. So that is the main aim of this session. Okay, so we all know the purpose of EP is to first make a diagnosis of arrhythmias, either stachy or bradyarrhythmias, and to also determine its mechanism of action. So the mechanism of the arrhythmia is very important, which can be diagnosed on EP, and also the type of the arrhythmia. So that means to confirm the diagnosis. Then also EP can also help us to do definitive therapy if possible. So it has both diagnostic and therapeutic purposes. Okay. So we also know that EP assessment is talking about the conductive properties of the heart. So it deals basically with the conductive properties of the heart. So, and we all know the conductive properties starts from the SA node with its internodal fibers and interatrial fibers. Then we have the AV node, we have the east bundle, we have the right and left bundle, and the left anterior and posterior fascicles of the left bundle, and we have its Purkinje system. Okay, so each of these segments of the conductive fibers have its major properties that can be assessed in each. That's number one. Number two, it can also be, as I said, used to determine the mechanism of whatever that arrhythmia that patient has. We'll come to the mechanism, and also it helps us to profile ablative solutions to that arrhythmias. Okay, that can be done in EP. So, slide. Now, one thing we do in EP is that the difference between intracardiac, someone's system is moving and moving, Okore, and it's kind of Dr. Okore Charles. I think it's creating some marks on the screen. So, because with those masks, it might be, you know, this is EP. So there can be marks you see on the screen that might confuse the person's waves. Okay, so I think I should stop sharing and reshare again. You agree with me, Dr. Eugene? Because there are a lot of marks on the screen and it might be difficult when we come to the tracing. Am I still
Yes,
audible?
yes, you're audible, Prof. We can try it. If it doesn't, I will try and see if I can play it from my end.
Okay, let me just remove, let me stop sharing and reshare. Okay, apologies for that. Apologies. Just a minute, I'm coming. Just also want to have my brown word side. Okay, so I guess let me know if it's the slide is showing now.
Yes, Prof. Please, it's showing.
Okay, great. Thank you. So, so one important thing about EP, that's electrophysiology between the intracardiac, as they usually say, intracardiac ECG, but technically it's actually electrophysiology. So, or intracardiac electrogram. The difference between this and surface ECG is that in surface ECG, it summarizes the chambers of the heart that it represents and we represent it in a waves. So look at the word summarizes. So that means if you are seeing a P wave, it's a summary of both the right and the left atrium, right? Contractility, right and left atrial contraction generates P wave. So it summarizes both chambers. If you see a QRS, that means it also summarizes left and right ventricular depolarization, right? So that is a summary of both. Okay. If you see a PR interval, it tells you the summary of the conduction time between the atrium and the ventricle through the AV node. So surface ECG summarizes, is summation. That is a bit different from EP. So in EP, it actually talks about the particular chamber that you are interrogating at that time. So it simply means if your catheter is in the right atrium, it is telling you everything happening in the right atrium, not left atrium. If your catheter has been moved to the left atrium, it will only tell you what is happening in the left atrium, not right atrium. Okay? If your catheter is in the right ventricle, it is specific for what? Right ventricle. So also if it's in the left ventricle. If your catheter is at the bundle AV node, which we call the east catheter, and that means it's telling you everything happening at the AV node. So it is not a summation. So that's the difference between, so one of the questions they can ask, what's the difference between surface ECG and intracardiac electrogram? The difference is that for surface ECG, it's a summary of whatever is happening in the chambers represented. But in intracardiac electrogram, it specifies the particular chamber interrogated. Hope we get that very well. Okay. So to move further, when we are doing EP, we have, as I said, we have catheters in specific chambers or tissues that you are assessing. So we can have a catheter in the right atrium, or we can have a catheter in the left atrium. We can have a catheter in the east bundle. We can have a catheter in the right ventricle. Okay? Or we can have a catheter in the left ventricle. So that means it will be assessing that chamber the catheter is located in. Okay. Now, standard EPs would have a representative of a catheter in the SA node. It will have a representative of a catheter in the east bundle or the AV node. It will have a catheter in the right ventricle, and it will have a catheter in the coronary sinus, CS, the CS catheter. Now, we all know that the CS, the coronary sinus, opens itself into the right atrium. So that means we gain entrance into the coronary sinus through the right atrium. That means your catheter, most of the time, all the punctures comes from the femoral vein. So either the right or the left femoral vein, then your catheters come to the inferior vena cava, and from the inferior vena cava, you access the right atrium, okay? So if you are putting the catheter in the right atrium, you just place the catheter close to the right atrium, usually close to the SA node. If you are passing the catheter to the coronary sinus, that means from the right atrium, you enter the orifice of the coronary sinus and pass your catheter through the coronary vein, yes, the coronary sinus itself. That's the venous drainage. Now, I want you to note something. When your catheter is in the coronary sinus, what is it doing? Remember, the coronary sinus is the most posterior structure of the heart. It's the most posterior structure. It is the venous drainage of the heart and is posteriorly located. So that means if a catheter is there, that means it is representing the chamber at the back. And we've previously described in this platform that the right chambers, that's right atrium and right ventricle, are anterior and to the right in relationship to the left chambers, that's the left atrium and left ventricle. So the right atrium is anterior and to the right of the left atrium. The right ventricle is anterior and to the right of the left ventricle. So it simply means that the left atrium is posterior and to the left compared to the right atrium, and the left ventricle is posterior and to the left compared to, in relationship to the right ventricle. So that means if a catheter is in the coronary sinus, we said is the most posterior structure. So that means that catheter is representing the left atrium and a segment of the left ventricle. So I want us to get it very well. So when they have a catheter in the coronary sinus, don't forget that the coronary sinus lies in the atrioventricular groove, right? So if it's lying in the groove, it is representing the left atrium and some far field of the left ventricle. Now, because the catheter comes in from the coronary sinus in the right atrium, some poles of that catheter will also be surfacing itself in the right atrium. So that means the proximal end of that catheter would be in the right atrium, while the distal end will be sitting directly in the CS, representing the left atrium, basically. So I want to be sure we get that point very well, because when we are looking at the tracing, it is very important that you need to know how the catheter represents the chamber, so that it can be very easy to understand the tracing when you start seeing the tracing. So I want to be sure we got that. So, for example, this is the catheter going to the CS. That's this broken lines. You can see how long that catheter is. Most of the time they use a decapolar catheter. So I will explain what that means shortly, but I want you to just see this catheter that goes into the CS posteriorly. It's represented with the broken lines, just to show you that it's not in the chamber, it's at the back of the chambers. And you can see that its proximal end is close to the right atrium, while its mid and distal ends are representing more of the left atrium at the back. Dr. Ozo, is this clear, sir?
Sure.
I want to be sure it's clear. Or
Yes,
do I need
it
to
is, sir.
repeat? Clear. Okay. 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 Now, so that brings us to the point of labeling the catheters. So I'll go further to explain again using this image that you can see this catheter touching the AV node. We can see the structure of the AV node here, followed by its east bundle and divided into right and left bundles. So you can see this catheter touching the AV node. So that is what you call the east catheter. So you can see it's representing the AV node and activities happening around the node between the AV node and the east bundle. So that means whatever is recording is telling us, and so it's telling us the property of the AV node and the east bundle. But one important thing, if you look at this catheter very well, that you can see like there are 4 poles, right? 1, 2, 3, 4. Each of these poles are electrodes. So that means that you can see that a segment of this catheter, the AV node catheter, also called the east catheter, some segment is sitting in the right atrium, right? This another segment is touching the AV node and the east, and that is close to the ventricles. So what am I saying here? What we are saying here is that the east catheter you are seeing has a property of detecting some things in the right atrium because some of its electrodes are sitting in the right atrium. It has the property of detecting what is happening in the AV node and the east bundle because it's touching that tissue. And it also has a property of seeing some far field activity in the right ventricle. Okay? So that is the property of this catheter that is sitting for the east bundle, east catheter. Is that clear also? Dr. Basui. I just need to be sure people have.
It is. It
Yeah.
is, Prof.
It is. Okay, great. So we've described the properties of the catheter that will go into the coronary sinus, that is representing basically the left atrium because it's sitting at the coronary sinus, which is the most posterior structure. And because it has some proximal end that entered the coronary sinus orifice from the right atrium, it can also signally see activities happening in the right atrium. Okay, so most catheter, we'll still come to the description of this catheter itself. Now, one other important thing is to note that you can also put a catheter in the right ventricle. So we can see this catheter in the right ventricle, right? So that means since it's deeply seated in the right ventricle, the only thing it's going to be sensing will be activity in the right ventricle. It cannot sense activity in the right atrium because it's deeply seated in the right ventricle. The right atrial catheter, which is also called the HRA, high right atrium catheter, usually close to the SA node, is deeply seated in the right atrium. So it cannot tell you anything that's happening in the right ventricle. Neither can it tell you anything that is happening in the left atrium. It can't tell you anything that is happening in the AV node because it's deeply seated in the right atrium. But the catheters that are bridging chambers, I've described them. The east bundle is bridging between right atrium, AV node, and the right ventricle. You can see it clearly in this. So that means you can see 3 activities happening on the east catheter: atrial, east AV node activity, and right ventricle activity. Hope that is clear. And we can see that the CS also bridging chambers. It has some end in the right atrium. It has most of his body seated in the coronary sinus, which is bridging between and the coronary sinus, we said, is sitting in the atrioventricular groove. So that means it's seeing more of the left atrium and some far field activity in the left ventricle. Okay? So I want to be sure this is clear. When we understand this activity, when we are looking at the waves, it will be very clear and very easy to trace. Any question at this stage? Doctor, any question, Chief, anyone? If something is not clear, please can we ask? My fantastic friend, Dr. Okeda, is it clear? Okay. Dr. Eugene, am I still audible?
Prof, you are very audible, sir.
I just want to be sure people are going along with this thing. Okay. So that when we are assessing the waves, and it will just a giveaway. Very easy and well understood. Okay. So another important thing I want to draw attention to is the nature of these catheters. We've already talked about the location of the catheters and what they are representing. So let's talk about the nature of these catheters. So every catheter you see, so for the right atrial catheter, the right ventricular catheter, the east catheter, usually just have 4 poles. So we can see the poles were labeled white. So 1, 2, 3, 4 poles. Now, so there are electrodes, okay, that can sense electrical activity. So just the same way you put ECG electrodes on the surface ECG or surface of the chest of the patient. So the same thing, there are there are electrodes, intracardiac electrodes that can represent electrical activity or detect electrical activity. Now, the difference between these 4-pole catheters and the CS catheter, which is 10 poles, also called decapolar, tetrapolar, decapolar, is that the CS catheter, because of its nature of detecting many activities around the left atrium, left ventricle, and the right atrium, it has 10 poles along its course. So each of those poles can also detect electrical activity. Okay, that is one important information we should have. So if you are labeling the CS catheter, usually label it from the tip of the catheter. So that means you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 decapolar, 10 poles, right? So it means that the 1 and 2 pole are deeply seated in behind the left atrium, okay? While the 9 and 10 will be representing more of the right atrium. So the 9 and 10 are called the proximal pole, while the number 1 and number 2, because they are far away, they are the distal poles. A proximal pole is a pole that is closer to the physician that is operating the procedure. The distal pole is the pole that is farther away from the operator. Okay? So 1 and 2 is distal to the person operating doing the procedure, but 9 and 10 is closer, proximal to the person doing the procedure. So it's the proximal pole and the distal pole. So the same way you have for the east catheter, you can have a proximal east and a distal east. Hope we're getting it. The same way you can choose a proximal RV catheter and the distal RV catheter. The same way you can also determine if you want to do proximal and distal for HRA. But most of the time, they will just leave HRA as HRA, RV as RV. East catheter most time can be as east or as proximal and distal east. But CS is always CS 1 to 10. Always CS 1 to 10. Except they want to divide it into proximal and distal. But most of the time it will be made CS 1 to 10 because it helps you to determine a lot of things when assessing, especially when you're assessing for AVRT. That's Wolf Parkinson White. You need the 10 poles to know the location. And why are we needing the 10 poles? For example, we all know that when the patient has AVRT, that's Wolf Parkinson White, he has a bypass tract, right? An accessory pathway. So the accessory pathway can be located anywhere, right? It can be located in the right chambers, that means bridging the right atrium and right ventricle, or it can be located it can be a left-sided tract. And even though it's left-sided tract, it can be located close to the lateral wall, depending on the cues you get from the ECG. It can be located around the mitral valve. It can be located around the septum, anterior or posterior wall. Okay, that is why to know that location of that tract, that is why you need these temples, because these temples can easily tell you where the bypass tract is manifesting from. So you can see these temples now, like as if something is cycling around the wall of the left atrium. So any bypass tract that is coming close to the lateral wall, the CS1 and 2 will pick it. Are we getting it? Any tract that is going around the medial layer of the mitral valve, your CS5 and 6 can actually pick that thing. Any tract that is playing around the AV node or in the right chambers, your CS9 and 10 can easily pick it. So that is why a decapolar catheter is very important when you are interrogating the coronary sinus. Hope this is clear, because it seems only Dr. Eugene that is talking.
Well, I believe
It's
we are
clear,
following. That's why.
It's clear. It's clear,
Okay.
Paul.
So if there's something not clear, let me quickly on time. Okay. So I just want I want to recap about this CS catheter very well, because most times, most of the reason we will send patient for EP will be because maybe we saw a Wolf Parkinson White AVRT, and also sometimes AVNRT, right? So AVRT, Wolf Parkinson White, means that the bypass tract can be anywhere. Can be anywhere as long as it's bridging right atrium and right ventricle. It can be anywhere. So you need a catheter that will be touching that tract and be able to sense where that tract is located. So that is why a decapolar catheter is very important when you are putting it in the CS. You cannot put a short pole catheter in the CS, or else you won't be able to bridge the layers of where the bypass tract will be passing through. Okay? Number one. Number two, we should understand is that, for example, when a patient has atrial flutter, we know atrial flutter can happen around the tricuspid valve, right? So the bridging between the inferior vena cava, the tricuspid valve, isthmus, so which we call the CVI, that's the cavo tricuspid, CTI, cavo tricuspid isthmus. You will need a catheter that can sometimes rotate around. So you can sometimes have a halo catheter. So a halo catheter, I'm sorry I didn't put the picture here, is a catheter that looks like a pigtail catheter, or a catheter that looks like a circle. And that circle, each of the pole has electrodes on the circle, right? So imagine putting a circular catheter here. That means that it can tell you activity at each segment of this right atrium. So if the tract is if it's starting from the tricuspid valve arena, the area of the catheter sitting around that area will pick it up. If it is starting at the roof of the right atrium, the area of the catheter sitting around that place will pick it up. I'm just trying to emphasize the importance of a catheter having many poles. The purpose is ability to pick where a bypass tract or where an electrical activity is being generated, so that it can help you to determine the mechanism of the arrhythmia. Okay? So, I guess I've buttressed a lot about these catheters. So since we understood these catheters very well, then we all know when we talk about the mechanism of arrhythmia, we have automaticity. These lectures we've had before, triggered activity and reentrant. So I won't want to waste our time on this because we have a duty of what to do. Also, we all know that mechanism of SVT, we always want to know what type of SVT we are dealing with, because it has many differentials, right? And I also want to waste our time on these differentials. But there's one important point I want to bring to our notice when talking about RP and PR interval. This is something we know. We know that when we're talking about RP interval, that means between the QRS and the P wave. And the PR interval will be between the P wave and the QRS, right? So we've heard of long RP and short RP. So we say, okay, somebody has a short RP interval, and there can be many differentials. So if let me repeat that. We're trying to differentiate between RP interval and a PR interval, right? Okay, so let me use this slide to explain what I'm trying to say. We're talking about RP and PR interval. So you are trying to say that when somebody has, sorry, apologies. So when somebody has a short RP interval, this is what you see. It means that the P wave is very close to the R wave. When somebody has a long RP interval, that means the P wave is far away. This is long RP interval. The P wave is far away from the QRS. All right. Now, it's said that when somebody has a RP interval less than 70 milliseconds, he likely has a short RP interval. And that comes to the discussion of the reentrant arrhythmia. So when somebody has a short RP interval, you are trying to say this is the mechanism, reentrant activity. So if he has a short RP interval, you are trying to say that most likely maybe the person has an AV nodal reentrant activity, AV nodal reentrant. I guess we've done this lecture before because I don't want to just waste our time on things we know. Right, Dr. Eugene?
Yes,
Please
bro.
go. Please
Yes,
go.
bro.
Okay. All right. So I'll just summarize this chart to tell us that in the AV node, most patients would have dual pathway, but one pathway will be inactive, right? So most patients have dual pathway, the alpha and the beta pathway, or the fast and slow pathway. So it means that one pathway, because it's fast, is always active, while the slow pathway is usually inactive, right? So it means that when electrical activity comes from the atrium, right? It will pass through the AV node, and one of the fibers both fibers will actually pick it. But because the fast pathway is faster, right? So it will conduct faster to the ventricles or to the east bundle than the slow pathway. So that means that the electrical activity entering the slow pathway will be blocked because it is slow. It can't depolarize the east bundle anymore because the east bundle is still in its absolute refractory period. So absolute refractory period simply means that the period where you cannot depolarize that tissue no matter the stimulation you give to it. So it's an absolute refractory period, right? So it simply means that every time you conduct through the fast pathway and the slow pathway is now coming later, the east bundle is refractory, so it's not going to allow any conduction through it. Okay, good. So if we have that, then there are some situations where that slow fibers can be active. So it means that when electrical activities come through it, even though it is slow, its slowness means that conduction through it is slow. That's the meaning of why it is slow fibers, right? There can be time where there can be premature complex that can enter into the tract, that it conducts through the slow fibers, but by the time the slow fibers is getting to the east bundle, this bundle is now in its relative refractory period. So in a relative refractory period, you can still stimulate that tissue if you have a sufficient threshold. And so that means that east bundle can now conduct through its tissue, and the fast pathway, the fast tract, which is also now in its relative refractory period, can conduct in a retrograde manner back to the atrium. So in that phase, that means that the east bundle, which has received a premature conduction, has successfully entered into the tract of the east bundle and the fast pathway. So since that successfully entered into the tract, then reentrance can now happen. So that means that the fast pathway will now take it retrogradely back to the atrium. And by the time you are getting back to the slow pathway, remember the slow pathway has slow conduction, but has a very fast or short refractory period. It has a very short refractory period. It has slow conduction, but has a short refractory period, meaning that it can easily recover from electrical activity. So because of the nature of the slow, because of its fast, short refractory period, when the fast pathway is taking the activity back to the atrium, it can reconduct back to the slow pathway, because the slow pathway can now be re-excited because of its short refractory period. So then it takes it back into the tract to the east bundle, and the fast pathway, which is now in its relative refractory period, cannot take it back again into the atrium. And that vicious cycle continues, and that is where you have your reentrant tachycardia. Okay? So that's why you have your reentrant tachycardia in most of the time in the AV node. Okay? So these are the patients you will say they have AV nodal, because the slow pathway, the fast pathway are domiciled in the AV node. So that's why they are called AV nodal reentrant tachycardia. So in that kind of a patient, when you look at their ECG, what will be happening is that the time, because of the slowness of the slow pathway, and which is going to excite the ventricles now, conducting through the east bundle. By the time you are generating your QRS, the fast pathway has conducted very rapidly back into the atrium. So the P wave and the QRS will be happening at the same time. So if you look at the ECG, most of the time the P wave will be buried inside the QRS. That follows this reentrant tachycardia nature of the fibers, because the slow pathway is slow to conduct antigradely to stimulate the AV node. When the reentrant has started though, and the fast pathway is so rapid to conduct and pass the conduction back into the atrium, by the time you are causing ventricular depolarization, QRS, you are also causing atrial depolarization at the same time. So if a patient has typical AV nodal reentrant tachycardia, if a patient has typical AV nodal reentrant tachycardia, P wave and QRS will be happening at the same time. They'll be buried in each other. Why am I saying this? So that when you are looking at the surface ECG, you might not be able to decipher that when you're looking at the surface ECG. But if you are doing your EP studies, that is what you are going to see. You will see P wave being depolarized at the same time when QRS is being the ventricle is being depolarized. You'll be seeing P wave at the same time you'll be seeing QRS, meaning that you'll be seeing atrial depolarization at the same time you are seeing ventricular depolarization. So that tells you that this diagnosis is what? AV nodal reentrant tachycardia, because everything is happening in a compacted AV node. Okay, they are not far from each other. So in that kind of a patient, they will have a short RP interval, because QRS R is happening at the same time with the P wave. So the duration between the QRS and the P wave, which is happening retrogradely, is going to be very short. So you'll be seeing P wave either happening on top of the QRS or very close to the QRS. So that is a short RP activity. So that is a strong differential for AV nodal reentrant tachycardia. Okay? Which we can see when we are doing EP studies. I go to the next mechanism of arrhythmia, which we also would be able to diagnose during EP study, is the AV reentrant. This is not nodal now. We said the first one was nodal, but this one, it is atrioventricular reentrant tachycardia, is not domiciled in the AV node. For AV nodal reentrant tachycardia, the fast and the slow pathway are buried in the AV node. Just to show you this back. So the slow fiber, the fast fiber are buried in the AV node in AV nodal reentrant tachycardia. Okay? But that is very different from AV reentrant tachycardia. There's no nodal there. So it's not, the tract is not domiciled in the AV node for AV reentrant tachycardia. For AV reentrant tachycardia, you have a fiber, one fiber in the AV node, and you have the accessory pathway outside the AV node. As we said, the accessory pathway can be anywhere It can be in the right atrioventricular wall. It can be on the interatrial septum. It can be around the mitral valve. It can be close to the lateral wall of the left ventricle. Anywhere. Okay. It can also be close to the AV node, but not inside the AV node. So that's what you call paraisian. It's close to the AV node and the east bundle, but it's not in the node. So that is a paraisian pathway, but it's still an AV reentrant tachycardia, not a nodal tachycardia, not AV nodal tachycardia. Okay. All right. So that means in AV reentrant tachycardia, we've done this mechanism before. We've talked about the retrograde and we've talked about antidromic and autodromic. So autodromic simply means that in the reentrant tachycardia cycle, when it started, it uses the AV node, bundle of ease, right and left bundle, and the Purkinje as its antegrade flow, meaning that conduction is flowing down through AV nodes to the bundle of ease and every other to the Purkinje. It's flowing downward to the ventricle. While it is going back upward through the accessory pathway. We said the accessory pathway can be in the right ventricle or in the left ventricle, anywhere away from the AV node, right? So it means that if it is coming down through the bundles, AV node and its conducting fibers, and is going up backward through the accessory pathway to the atrium, you will say that this patient has autodromic. Autodromic, why is it important autodromic? Because by the time you have your QRS will be a narrow QRS. Why? Why is it a narrow QRS? A narrow QRS because what is stimulating the ventricle is the conduction that is coming through the normal tract. The normal tract is the east bundle, AV node east bundle, and the right and left bundle. So it will stimulate the ventricle and it will conduct to the right and left ventricle at the same time, and you will generate a narrow QRS complex. But it's still a arrhythmia tachycardia because it's having its accessory pathway go back up through the accessory pathway, which is the bundle of Kent in Wolf Parkinson White. Okay. And that accessory pathway is the one that is now generating the tachycardia. So that is autodromic. Autodromic because the QRS is narrow. It is using the normal conducting fibers to depolarize the ventricles. Now, antidromic, opposite direction. That's opposite direction, antidromic. It simply means conduction is coming down to the ventricle through the accessory pathway. Remember, accessory pathway can be in any level, at any area. It will stimulate the ventricle, right? It will conduct through the myocyte. Then the myocyte will get close to the Purkinje fibers. Then the Purkinje fibers will now carry it into the bundle to the right bundle, left bundle, up into the bundle of it, up into the AV node. You can see in opposite direction. So when that is happening in opposite direction, it is antidromic. It is anti-normal direction. Okay? And that means your ventricular contraction will be wide QRS. Why is it wide QRS? It's wide QRS because accessory pathway we said is located in one area of the ventricle, right? Either the right ventricle, RV wall, or in the left ventricle, any area. And that same accessory pathway will now be the one to start depolarizing the tissue from that side. So that means you will first depolarize, if the accessory pathway in the right ventricle now, you will first depolarize the myocyte of the right ventricle, right? Then you will now continue to depolarize the myocyte of the left ventricle. That means it's taking longer time to depolarize the ventricle. If it's taking longer time to depolarize the ventricle, that means your QRS duration will be wide. We first said when we started this discussion that surface ECG tells you the summation of the chambers involved. So that means if you are saying QRS, that means you are saying both right and left ventricle, right, forms the QRS on your surface ECG. So that means if you have spent some 100 milliseconds to depolarize the right ventricle, and you're going to spend another 50 milliseconds to depolarize the left ventricle, then that means your QRS duration will be 150 milliseconds. So that means you have a wide QRS complex. So antidromic will give you a what? Wide QRS complex because of the nature of the way it's going to depolarize the ventricles. Is this clear? Any question at this stage?
Very clear, sir.
Okay. So that means we can move on. Abi?
Yes, please.
Okay. Okay, good. So we can now talk about some basic information when we talk about EP. So basic information you want to know when we discuss EP is that we first said EP can be used to determine arrhythmias, right? So you want to know what type of arrhythmia the patient is having. When we say arrhythmia, there's bradyarrhythmia, right? There's tachyarrhythmia. So EP can make that diagnosis. And then it can tell you the mechanism of the arrhythmia. Is it automaticity? Is it reentrant? Is it sorry. Okay, we talked about the three mechanism. Okay, now one important thing we should note is that remember, we are not just sending a patient to the cath lab for one particular diagnosis. As I said, you are making study for different possible diagnoses, right? So you want to know the property of the tissue itself. So when the patient comes in the cath lab, the question you want to ask yourself is that what is the normal property of these conducting fibers? Because that is what EP is all about. EP is not to go and study myocardial ischemia, right? It's not an angiogram. You are not going to study infarct. You are not going to study coronary aneurysm. It is for conduction, arrhythmias. Abi? So that means I need to know the properties of the electrical fibers, the conducting fibers. So what is the property of the SA node? What is the property of the AV node? What's the property of the East bundle and its Purkinjes, right? So for me to know their property, that means I must know a baseline. What are the expected baseline? What does this baseline represent? So now this SCL represents the sinus cycle length. Okay, it's trying to tell you the property of the SA node, right? What should be the cycle length of a normal cardiac cycle? Okay, I will still go to when we are showing looking at the waves, we understand what we mean. So that means between when SA node fires the first time and the next time it's going to fire again, what should be that time interval? So it means that if it is going beyond that time interval, either above or below, there's a problem with the SA node. Okay? So I will expect that the normal sinus cycle length, right, should be between 300 to 800 milliseconds. So it means that if it's above that, I can say, oh, there's bradyarrhythmia that is sinus bradyarrhythmia as a result of this SA node, or it is SA nodal disease. Okay? Now, another thing we want to know, I want you to note one thing, that the higher the milliseconds, the more the bradycardia. Okay? All right? Okay. So, because that is very important, the way we do the mathematics in EP. So if I say somebody has 1,000, that means the heart rate will be slower. If the shorter the milliseconds, the faster the heart rate. The higher the milliseconds, the slower the heart rate. Okay? Hope that's clear. So they are running in inverse proportional. Sorry, they are inversely proportional to each other. The longer the duration of conduction, the slower the heart rate will be. The shorter the duration of conduction in milliseconds, the faster the heart rate will be. I'm sure that is clear. Okay. So now there's also what you call sinus node reentrant tachycardia. Okay. When I'm submitting the slide, I'll put the full meaning of all these stuff. So sinus node reentrant tachycardia. So SNRT. So sinus node recovery time. Apologies for that. Sinus node recovery time. So what does that mean? So what we're trying to emphasize is this, that there's a way you can suppress the SA node. Okay? When you suppress the SA node, how long does it take to recover its pacemaker activity? SA node is the pacemaker of the heart. If you suppress it, how long does it take to recover its pacemaker activity? If it takes longer, that means that the SA node has a problem. It's diseased. Okay? So you expect it to be shorter. So how do we suppress the SA node? Very easy. All we need to do is to get a faster pacemaker in another tissue, okay, that can suppress the SA node. So if SA node is firing for that patient, is firing at 100 beats per minute, all we need to do is just stimulate another tissue that can fire at 150 beats per minute, faster than the SA node. And you know that the SA node, no matter how it fires, it won't fire more than 150 beats per minute. So if I'm firing at another segment at 180 beats per minute, that means I will be suppressing the SA node of the patient, right? Now, if I now stop firing, how long does it take for the SA node to recover and take over the pacemaker function of the heart of that patient? So that is what you call SA node recovery time. How long does it take to recover to take its function back? Okay? After suppressing it. So if its recovery time is longer than 1,500 milliseconds, then you can say that this person has SA node disease. So those are patients you will have that will say have sick sinus syndrome and all that. That's how you make that diagnosis. Okay? Hope that is clear. I will show us on the tracing when we start. I just want to understand. I want us to understand the meaning of all this activity, these baseline parameters.
So far, Prof,
Correct.
it's clear.
It's clear. Okay, thank you. So there's also what is called corrected sinus node recovery time. Okay. Now, always remember that not everybody's heart rates are the same. For example, for athletes now, we expect that they can be bradycardic at a time, but basically that does not mean they have a disease with the SA node. It's just because of the way the nature of they have conditioned their heart to be. So that does not mean they have SA node disease, right? So the same way when we calculate QT interval, and you need to do a corrected QT interval. Why? Because of heart rate variability. Heart rate variability, so that you will not we'll be making over diagnosis of SA node disease. So that's what gives us the corrected sinus node recovery time. So what is the function of this corrected sinus node recovery time? So it tells you that, remember we said we can suppress the SA node and wait for it to recover its pacemaker function, right? Good. And we expect that the duration should be less than 1,500 milliseconds. And as we said, some patients can be normally bradycardic, right? Like athletes. So that simply means that sometimes their SA node recovery time might take longer. We said the longer the duration of the conduction, the slower the heart rate. So some people can have 1,800. Does that mean that they have SA node disease in an athlete? No. How do we correct for this baseline? So that is why we talk about corrected sinus node recovery time. What does it mean? It simply means that you are going to compare your sinus node recovery time that you get to the baseline of the patient. So you have a patient that normally is an athlete, has a baseline of 50 beats per minute. Then I can get his baseline cycle length, which we call BCL. I will show you where we wrote the BCL. I just didn't want to confuse it with this. Baseline cycle length, meaning that this patient is having his normal SA nodal activity, and I measure a cycle length, the duration. If I subtract it from the sinus node recovery time, the standard discharge must be less than 500 milliseconds. So anything above that, then I can beat my chest to say that this person has SA nodal dysfunction. So that's the purpose of this corrected SA node recovery time. The same way we do QT duration. And because you did a QT duration of 600 milliseconds, you have to correct, Abi, for the baseline, either we are using the Barrett formula, whatever formula you're using, and it is with that corrected duration that you can actually say that patient actually has a prolonged QT or not. Right? So the same thing about SA node recovery time, you can correct for it using the baseline cycle length of the patient. So if I know the baseline cycle length, I subtract it from the SA node recovery time, that will be equal to the what? Corrected sinus node recovery time. Is that clear? So what we use as baseline to know the dysfunction of the SA node will be the corrected sinus node recovery time. Okay? So the other maneuvers we will do when we go into details in subsequent lectures of assessing the SA node, assessing the AV node, and things like that. But we should know this basic information for exam purpose. Okay. Now the next thing we want to look at is the AV node property. AV node and the East bundle property. Okay. So the AHHV is talking about the AV node and the East bundle. Now, tells us that the time interval it took. Remember, there's a catheter in the. Okay, so let me go into this picture back again to this catheter. So let's look at this catheter now, this yellow catheter. So you can see that there's a catheter touching the AV node, and we say some segment of this catheter will be sensing the right ventricle, right? Close to the east. Some segment of this catheter will be sensing the AV node, right? Okay, good. So the question is, what is the time interval between the impulse that is coming from the atrium getting to the AV node? The time interval between the impulse coming from the atrium getting to the AV node, that duration is AH. Okay? Time interval. Hope my network is still stable. Dr. Ojima, is my network still stable?
Yes, Prof. You are loud and clear, sir.
Okay, thank you. Thank you. Now, HV now is the time interval between the east and the ventricle. Is the HV. Okay? So that is where we use the word nodal and infranodal abnormality of the AV node. Time interval between atrium and AV and the AH is the conduction from the property of the atrium to the east across the AV node, and from the east to the ventricle. That time interval is HV. So anytime you see AH, you know you are talking about the node. When you're talking about HV, you are talking about below the node, infranodal. Okay? Nodal and what? Infranodal. And me and you know that there are some ART block, AV nodal blocks now that are nodal, right? First degree, AV, first degree AV block is nodal. Abi is a problem with the AV node. We also know that Weckenbaching, right? Weckenbach, that's Mobis type 1, is nodal, right? But we know that high-grade AV blocks is below the node, infranodal. So that is where you'll be talking about HV. Okay? So it simply means that if the person has a prolonged AH, you will know there is a problem with nodal. That kind of a patient, I will not likely do a pacemaker for the patient. But if the patient has prolonged HV below the node, infranodal, that's a high-grade AV block. That one is a high-risk patient. That one should get a pacemaker. Okay? So that's, I just had to come to this catheter to show us what it means. Okay? So that brings us to these parameters, this value that you expect that your AH normal duration should be this, 55 milliseconds to 125 milliseconds. And your HV should be 35 to 55 milliseconds. Those are the baseline you expect. So that means if the AH is prolonged, you will know there is a nodal problem. If the HV is prolonged, then you know that is more is a more serious problem. It's infranodal. Is this clear, sir?
Yes, sir.
Yes, please.
Okay, fantastic. So if this is clear, then let's start looking at the waves. Okay, so remember I showed us the AH, right? The HV. right? This is just diagram, just trying to describe that. I talked about SA nodal activity, okay? There we can calculate the cycle length, okay? Now, so if you look at this surface ECG now, okay, I think one last thing I should discuss before I go to that surface ECG is, in the SA node, we can also determine the property of the SA node sometimes in its, there can be blockage of the SA node, right? And the difference between sinus exit pulse and the sinus arrest, we know is about blockage in the SA node. And we know we also have the grade 1 to 3, SA node, grade 1, grade 2, grade 3. You can also make that diagnosis by looking at the intra nodal conduction in the SA node. What's the time interval between conduction being generated and leaving the node, the SA node itself? Get. So that is what we call the IACT, in inter nodal conduction time, interatrial, intra-atrial conduction time, IACT. Okay, so you're going to see that in this. So we have the intra-arterial conduction time. How do we know that? How do we know the conduction time? It's very simple and easy. It just tells you the conduction time between when the impulse was generated and the time it was first detected at the A end of the East catheter. Remember, we said this catheter has some portion in the atrium, right, which can detect the atrial activity. It has a portion touching the East bundle. It has a portion sensing the ventricle. Okay, so the time interval between when you generated your atrial activity in the SA node, which is detected by the atrial catheter. There's HRA catheter, high atrial catheter. The catheter is close to the SA node. And the time interval to the time it takes to get to the atrial activity of the East bundle, that time interval is the IACT. Okay? So if it's prolonged, it will tell you that there's a problem within the conduction activity in the SA node. Okay? So let's look at this surface ECG now. So this is the baseline information we need to have. Comparing your atrial the cardiac EGMs to the surface ECG. So anytime we are doing EP, you have your surface ECG on the patient. So at least 2 or 3 surface ECG, either V1, Li2, Li3 can be on the surface. Then you have the catheters you have that's representing the respective chamber. Standard, as I said, could be a catheter in the high right atrium, close to the SA node, a catheter in the east, touching the east bundle. Okay, we discussed that. A catheter in the coronary sinus, a catheter in the right ventricular apex. Okay, this is just a schematic diagram. We'll go to the normal waves downward. Now, good. When you have a catheter in the right atrium, just note that it should correspond with your surface ECG of P wave, right? We said surface ECG is a summation of whatever is happening in both chambers represented. So P wave represents atrium. So you're talking about right and left atriums summarized together. All right, good. So you have a catheter in the high right atrium now. So that means that catheter is only talking about right atrium. Okay? If you have a catheter in the left atrium, or the CS catheter is representing the left atrium, you can see the distance between the wave in the right atrium, how long it takes to get to the left atrium. You see that distance, the duration it takes, okay? That duration. So it tells you that the high right atrium is focusing on the right atrium, the CS catheter is focusing around the left atrium, right? The East, which is in between, is also in the right atrium, okay? Now, so if you are talking about the east and the right atrial catheter, it's only going to give you one deflection because we said this is far inside into the right atrium. It can only monitor what's happening in right atrium. So you're only going to see one deflection, which is atrial activity every time.
which is going to correspond to your P wave. Okay? So it's going to see only one deflection. It's very important when we're analyzing the EGM now. The next one is the East catheter. We said is bridging between the right atrium, is touching, yes, bridging between the right atrium, the E bundle, the AV node, and some segment, the distal end is looking at the ventricle, right? So that is why you see 3 waves on the East catheter. Atrial, right atrial activity, the East spike, and the ventricular activity. Do you see that? So with this, you can see it's bridging, right? So you can measure the time interval between the AH, that means atrial activity to get into the east, which is nodal activity now. AH is node. You can measure activity between the east and the ventricle, which is HV. Okay, infranode.
Hello, Paul.
Right?
Okay.
So you can see the importance of using. Sorry, apologies. Am I still audible?
Yeah, we are audible.
Am I?
Yes, sir.
We lost you
Yes,
briefly,
please.
but
Where did you miss? Yeah. So where did you miss the point? Please, where did I go off?
Oh, when
Talking about HV, sir.
the HV.
Okay, so we understood very well the AH. That the
Yes, sir.
AH is discussing the AV node, right?
Yes, sir.
Good. We said the HV is talking about conduction from the AV node or the east bundle to the ventricles, right? H means east bundle. So that means that the time interval between the conduction of activity from the east bundle to the ventricle is called the HV interval. So that is infranodal, below the AV node. Is that clear, sir? So this is what we are talking about. So we can see this picture. This is what we are talking about, that AH talks about activity coming from atrium to the east. Okay? AH. That is, everything is domiciled in the AV node. That's the property of the AV node. But HV talks about activity coming from the east bundle to the ventricle, HV. But remember that catheter is sitting just here. Hope I'm still audible.
Yes, sir.
Yes, you're audible.
So we are seeing this picture, right? So we can see the AH in this diagram, what is representing AV node, HV below the AV node, right? Okay. Why can the east catheter give us those two intervals? Is because, as we said up here, the east catheter, you can see this east catheter haloed with this pink color. It is touching the AV node and also touching the east bundle. It has a segment around the atrium, so it can detect activity happening at the low right atrium. It can detect activity happening at the AV node at the east, and its far end can also detect activity happening around the right ventricle. So that is why we can get an AH interval and HV interval from this catheter, because of the way it is bridging the atrium and the ventricle. Is that clear, sir?
Yes, Pastor.
Okay, great. Thank you. All right, so that means we can understand that on that wave now. So we can now understand the meaning of AH and HV on the electrogram. Okay, on the EGM. All right, so we can move further to now talk about the coronary sinus. Don't forget, we said the coronary sinus catheter has gone into the CS, right? It's at the back of the left atrium. So let me use this diagram very well. That this catheter is the CS catheter. It's at the back of the left atrium. Abi? Remember we said that coronary sinus is sitting in the groove between the atrium and the ventricle, left atrium and left ventricle. So it's called atrioventricular groove, right? The artery that runs on that groove is the left circumflex artery. Okay. So now what we are trying to emphasize here is that because it's sitting in between two chambers, it can detect what is happening in the left atrium and also detect what is happening in the left ventricle, right? So it can give you two waves, left atrial wave and left ventricular wave. Is that clear? Right? Is that clear?
Yes, Prof. It's clear.
Okay. So that is why if you come to this EGM now, that's why if you come to this EGM, you can see on this coronary sinus, you can see A, Abi, but this A represents left atrium, right? Abi? And you can see V, Abi, and this V represents left ventricle. Do you see something now, right? So let's relate this to the surface ECG we are seeing. So I want us to see the surface ECG very well because it will help us very well. So don't forget, we said surface ECG is a summation of the chamber it is representing. So that means if you see a P wave, you are talking about right atrium and left atrium summarized together as P wave. So if you can look at the EGM of right atrium, Abi, and you can see the EGM of left atrium put together, Abi, you can see that occupies the duration of the P wave. True or false on this?
True.
Great. Thank you very much. The same thing, look at the QRS, sir. We said the QRS summarized the two ventricles putridization together, Abi. Good. So you see right and left ventricle inside, Abi. So I want you to look at this right ventricular apical catheter. That means that this right ventricular catheter is in the right ventricle, right? The only thing it's going to see is right ventricle because it is deeply seated in the right ventricle. So looking at this description, where's the description? So you can see that this right ventricular catheter now is deeply seated in the right ventricle, close to the apex, Abi. So the only thing it's going to see is right ventricle activity. It will not see left ventricle activity. It will not see east activity. It will not see atrium activity because it's deeply seated in the what? Right ventricle. Unlike, look at this east catheter. It's bridging right atrium and right ventricle. You can see the way it is sitting, Abi, and it's touching the AV node. So that's why that one can bridge. Hope that is clear. Right atrium is far into the right atrium, so it can only see right atrium. One thing I want us to see here is that we said this CS catheter can see left ventricle. So that means if I summarize the duration of right ventricular depolarization on the EGM and left ventricular depolarization on the EGM, then I can know the duration of the QRS. So that is what we're seeing here. So that's what we can see here. So you can see right ventricular deflection is only seeing right ventricle. CS we said is going to be sensing far field left ventricle, right? So if you summarize it together, you can see that they will summarize your QRS duration. Is that clear? Okay, so I guess we can move on, Abi.
Yes, please.
Okay, great. Now, another thing I want us to draw our attention to is this. Remember, we said the East catheter tells you the property of the AV node and the East, Abi? So that means if I summarize AH duration and HV duration, that means it will tell me the time of conduction around the AV node activity, Abi? Either nodal or infranodal. It's all is a AV node complex activity. Okay? So that means if I had that duration together, I should be able to get my PR interval. Is that clear? So that means that your East catheter is actually describing nodal, the AV node property and its and the East. So AV node East function, East activity is ably represented on your surface ECG as PR interval. Okay? Hope that's clear. Okay, so if we move on, there's one important information I need to retrace our step to. Is the information I talked about the decapolar nature of the CS catheter. Remember we said you start labeling it from the distal end. 1, 2, 3, 4, till you get to 10. So 9 and 10 is more proximal, closer to the right atrium. Abi? So that means if I see a deflection in 9 and 10 wave, which we'll still see on EGM now, 9 and 10, that means it's talking about right atrium. If I see deflection in 1 and 2, it's talking about far area of the left atrium. Okay? It's very important to. I'll still draw our attention back to this when I show us the EGM that represent the full CS catheter. Okay? Good. So let's move on. So we talked about basics, baseline cycle length. The baseline cycle length. Baseline cycle length means that what's the time interval between one P wave and the next P wave? Okay, that means trial activity. That duration is in that person's baseline cycle length, and that you can use to determine the patient's heart rate. Is my network still audible, sir?
Prof, you are very audible, sir.
Okay, good. So if I have my baseline cycle length, I can tell the heart rate of the patient, the rate at which the SA node is firing. Okay. And we said that if I suppress this SA node by overfiring it, the time it takes for that SA node to recover its function is called the sinus node recovery time. Abi? Okay, so let me show you this. Let me just show you a normal EGM. So now, in this EGM, it's very clear and straightforward. We said you were going to have a surface ECG, right? I'll still come back to the sinus node recovery time and the baseline cycle length later, but I want to show you what a full EGM represents. So you have your surface ECG, as I said, you can have lead 1, AVF, V1, whatever you want to represent. So most times they will give you one limb lead, one augmented limb lead, and one chest lead, okay? But you can represent as number as you want. Number 2 is you now have your catheters, and they will help you label where your catheter is being positioned. So that means your catheter is positioned in the coronary sinus, they will help you label it as CS, coronary sinus catheter. If your catheter is in the right ventricle, it will be labeled like that. And right atrium, it will be labeled like so. And the east catheter, HBE, it will be labeled like that. Now, so let's talk about the division of this. Remember I said you can divide the right ventricle into proximal and distal. But for ease of communication, they only give us one end, the right ventricle. That means the catheter can only see anything happening in the right ventricle. And that's why if you are seeing the deflection, you can see that it's corresponding to the QRS, right? You can see if you trace all this deflection, it's just corresponding to the what? QRS. So it tells you that it's in the right ventricle. It's only sensing the right ventricle, right? Now, if you look at this surface ECG, you can see this P wave here where my arrow is, right? And if you can see the HRA catheter, right HR catheter, you can see just representing P wave, everything happening in the right atrium. You are not seeing any other deflection because it's just right atrium that is what is seen. It's far high into the right atrium. That's clear, Abi? East catheter. We said it is bridging. Atrium A is east bundle and the ventricle, right? So you can now measure your AH and HV. So anyone that is abnormal, you can say if it's a nodal problem or infranodal problem, right? That's clear, Abi? So we said distal is just that you are talking about the distal end of the catheter. Proximal, you are talking about the proximal end of the catheter. I think we understood that, Abi? Or do I need to re-emphasize that?
We understand,
Doctor,
sir.
we understand. Okay, please, so that we can move on and we can save time. The next thing is the CS catheter. This is what I want us to focus on now. The CS catheter. We told you that CS catheter is CS1 to 10. Decapolar catheter. Decapolar catheter, right? So now, the distal end, we said you start labeling it from the distal end. I go back to this picture again. Apologies for taking it and re-emphasizing this. So start labeling from distal end. You can see that distal end is closer to the lateral end of the left atrium and ventricle, right? 1, 2, 3, 4, 5, 6. So that means 9 and 10 is closer to the right atrium. So that means if I see any deflection in 9 and 10, it's telling me the deflection that is in the right atrium. If I say deflection in the 1 and 2, it's telling me a deflection at the far end of the left atrium. Hope that's clear. Okay, so that brings us to this fact on this EGM. So if you are seeing a deflection in CS1 and 2, you can see that you're talking about far end of the left atrium. Abi? If you are seeing a deflection in 9 and 10, you can see it's more proximal and it's more earlier than 1 and 2. So you can see, so if you trace this thing down now, you find out that with the timing, you will notice that 9 and 10 is earlier than 1 and 2. Why is this important? It's important because this is where you can use to know where your aberrant tract is hiding. If CS1 and 2, as we said, is representing the lateral end of the left atrium, 9 and 10 is representing the right atrial end of the catheter. So that means that if I see a deflection in 1 and 2 that is far earlier than 9 and 10, it's telling me that there's an aberrant tract that is firing faster than the proximal conducting fibers. So I can tell the patient that your accessory pathway is close to the lateral wall of the left atrium. If I see a deflection faster at 5 and 6, I can easily tell the patient that it looks like your accessory pathway is close to the interatrial septum, okay, or close to the interventricular septum, septal, because it is the one firing faster than the others. So that I want you to understand and enjoy the benefit of CS1 to 10. Is that clear?
Yes, sir.
Okay, good. So that because that brings to the fact of identifying the accessory pathway in AVRT. AV in Wolf Parkinson White, AV AV reentrant. It's different from AV nodal reentrant cardia. Good. Now, the next thing I want us to see is that, remember we said that if a patient has AV nodal reentrant tachycardia, from the mechanism of arrhythmia that we explained, that everything is happening around the AV node, Abi? It simply means that you are depolarizing the atrium and the ventricle at the same time, Abi? Because the fibers are compacted in the AV node, the fast and the slow pathway. They are happening. So I'll go back to this wave. So this is AV node. The slow pathway, the fast pathway is in the AV node. So you are depolarizing. So when that reentrant tachycardia is initiated, that means that you are depolarizing the ventricle and the atrium at the same time. So that means that atrial activity and ventricular activity are going to be merged together at the same time. So that means that if I look at an EGM, that AHV is merged to 1. A is on top of, that means HRA is on top of right ventricle. Meaning that if you move the right ventricle here now, right atrium is here. All the HV, AHV, they are all here. And all the CS are all lined up together in one single file. Then I can say that this patient has AV nodal reentrant tachycardia because the fibers that is generating these things are domiciled in the AV node and is causing activation of the atrium and the ventricle at the same time, giving me a single file. Is that mechanism clear? So can you see how I've tried to help you differentiate AV NRT from AVRT? So that when we are looking at the questions now, you'll be able to understand the answers to the questions. Any question now?
Prof, please, can you just repeat that, the difference? Because my network, I was not hearing you, sir.
Okay. I'll repeat it. I just want to be sure we are clear. I'll repeat. Still go back to it. So I go back to this reentrant tachycardia again. So let me first use this AV nodal reentrant tachycardia again. We said we've explained this mechanism. That's why I just had to put this picture in this mechanism. Okay. So we have said that if it's a reentrant tachycardia in the AV node, so fast pathways in the AV node, slow pathways in the AV node. So one of the pathway, the slow pathway is activating the activating the ventricle, QRS. And the fast pathway, because of its fast nature of taking the impulse upward fast, it's activating the atrium at the same time. So because of its fast nature, the wave is carried back retrogradely into the atrium to depolarize the atrium, while the antigradely, the slow pathway is depolarizing the ventricle at the same time. So that means that atrial depolarization and ventricular depolarization are happening at the same time. Okay? So that means if I see my ECG, surface ECG, P wave will be buried inside the QRS because atrium activation, depolarization, and ventricular depolarization is happening at the same time. So P wave is embedded or very close to the QRS. Okay? So that means that if I look at the EGM now, remember EGM will show me P wave, it will separate atrial activity from ventricular activity. So that means that if I look at my EGM and I can see HRA deflected, right ventricle wave deflected, all the East AHV merge into one single file at the same time, then I can say that the patient has AV nodal reentrant tachycardia. Do we get that, sir? So if I go to this EGM now, and I want to just imagine that you push this RV deflection here on top of the HRA deflection, and all your AHV merge into one, and you push it to this same single file, and all your CS catheter deflection, they are all merged into a single file down, single straight line. That means that all the ventricular and atrial depolarization are happening at the same time. True or false? Chief, sir, am I audible, sir?
Yes.
Yes, sir.
So that means that is AV nodal reentrant tachycardia because everything is depolarizing. We are depolarizing atrium, ventricle, everything is happening at the same time. So when you see that kind of deflection on your EGM, that is an AV nodal reentrant tachycardia. Is that clear?
Yes, sir.
Good. For AV, I want to be sure that one is because that's very easy to pick. Very easy to pick. Okay. Now I went further to describe that of AVRT to you, Wolf Parkinson White. I use this catheter. Okay. Now I want you to imagine something else. Let's say we said the tract accessory pathway can be anywhere outside the AV node. Right ventricle, left ventricle. Abi? I'm apologizing for repeating the same thing because if you get this mechanism very well, when you're looking at the AGM, you will just pick it once and for all. Bam, this is this. So apologies for going back to these diagrams. So let's assume, I want you to assume something, sir, that this accessory pathway is in the left atrium, bridging the left atrium to the left ventricle lateral wall. Just assume where my arrow is. Hope you can see my arrow.
Yes, sir.
Yes, please.
Okay, so I want you to just invert this image you are seeing, that this accessory part that is in the right ventricle, imagine push it to the left ventricle on this lateral wall. So it means that the only thing that can pick that thing is that my CS catheter is the one that will access the left atrium, Abi. So that means that the most distal end of my CS catheter is where 1 and 2,
One
Abi,
and two.
and it's touching the accessory pathway, Abi. If the accessory pathway is on this lateral wall low, I hope you can imagine it, yeah.
Yes, sir.
So that means that if I look at my AGM and CS 1 and 2 is firing before CS 9 and 10, it tells me that the accessory pathway is the one firing faster than the other conducting fibers. Because on a normal day, let's talk about the normal flow. Normal flow is that SA node will generate, abi? It will come to AV node, abi? CS9 and 10 is close to the AV node there in the right atrium, abi? It should, and when you generate it from the right atrium here, then it will spread to the left atrium, abi? So I expect CS9 and 10 to deflect first before CS1 and 2. True or false?
True.
True, sir.
So now, my catheter is in the CS, and my catheter is telling me that CS1 and 2 is firing before CS9 and 10. That means that the person that is generating the pacemaker is from 1 and 2. Abi? And is the one now deflecting down before it gets to CS9 and 10. So I can easily tell the patient that your accessory pathway, the person that is determining your pacemaker reentrant tachycardia, is in the lateral wall. Hope you get that, sir. So that comes to the point that when I look at the EGM, if I look at this EGM, this is a normal EGM now. I expect 9 and 10 to be earlier than 1 and 2. Abi? If you look at this tracing very well, 9 and 10 is earlier than 1 and 2. But if 1 and 2 is now much earlier than 9 and 10, that means that accessory pathway is in the lateral wall of the what? Left atrium. Abi? So that tells me that this is AVRT, not AVNRT. The same thing, if 5 and 6 is earlier than 9 and 10, it tells me, so if 5 and 6 is earlier than 9 and 10, so I want us to see this image very well. So I'll go back to this image now. This is 1 and 2. This is 9 and 10. Conduction should flow from right atrium down to the left atrium, right? So 9 and 10 should be earlier than 1 and 2. Now, 5 and 6 is not earlier than 9 and 10. It tells me that the accessory pathway is around the mitral valve or close to the septum, septal. Can you see? 7 and 8 earlier than 9 and 10 is more closer to the septum or closer to the alveolar tract. Do you get that? So all those will tell me that this is an accessory pathway. It is not AV nodal problem. It's an accessory pathway problem. So it automatically makes the diagnosis of what? Wolff Parkinson White or AVRT. Is that clear?
Yes, sir.
Okay. So you can see the importance of having your CS catheter labeled from 1 to 10. It can easily pick where the location of the accessory pathway is. Okay. Okay. All right. So if the accessory, so one last thing I want to say is that if the accessory pathway is on the right wall, what I need to do is to take another catheter to the right wall. And I will find out that electrical activity is faster than 9 and 10. Then I can tell you that the person that is faster here is the one determining the pacemaker than 9 and 10. So I can tell the patient that is close to the right ventricular wall. Hope that is clear.
Yes, please.
Okay, great. So what's the catheter used for that one? They call it ablation catheter. I'll just see the ABL catheter, ablation catheter. I'll just put it there and I say deflection is faster here than getting to CS9 and 10. So the problem is from here. So that's how it goes. So you can see that making diagnosis, basic EP diagnosis of AVRT, AVNRT is very easy. Okay. So that's why Bromwood will put it in their questions. Okay. No, remember, we now said that we have, if AH is prolonged, I can tell you that the problem is in the AV node. Abi? If HV is prolonged, I can tell you that the problem is infranodal. Abi? We've actually trashed that. Abi? That one is straightforward now. Okay, so can we move on now?
Yes, please.
Okay, great. So this is still another EGM just to emphasize how we do the measurements, how they measure the PA is also called the IACT, that is intra atrial conduction time. Okay, the time it takes from the wave to the deflection to happen or SA node to discharge and is getting to the East A catheter. Okay, so the East catheter has the A component, has the H component, has the V component, AHHV. So that time interval is called the ICT interval. So it's just testing the property of the SA node. Okay, so we already understood HV interval and AH interval. Okay, now we also kind talked about the cycle length, baseline cycle length. That means you are not pacing the heart, just the normal rhythm of the patient. So I can time the interval between the first A deflection, HA deflection, or the first P wave to the next P wave. So that time interval is a cycle, right? So that's the baseline cycle length. Okay? So remember, we now said that we can do what is called sinus node recovery time. Abi? Sinus node recovery time, as I previously explained, that you can suppress the SA node by stimulating one area in the chamber with all those catheters that you see. They can be used to pace, and they can also used to detect deflection or electrical activity. So it can do two functions: pace and also determine electrical conduction activity. Okay, now if I can pace from any of those catheters, and that means I can pace any other tissue away from the SA node. Abi? So I can decide to start pacing the patient faster than the normal sinus rate of the patient. So that is what you can now see as. So anytime you see S1, S1, or S2, it's talking about pacing. You're already pacing. So you will see that deflection on that catheter you are using. So now we are pacing through the HRA, that's the high right atrial catheter, faster than the cycle length of that patient. So you want to suppress the SA node of that patient, Abi, by generating another pacemaker from somewhere. So when you now stop pacing, the question is, how long does it take for the patient's normal SA node activity to rehappen? Do you get that now? So the time interval from when you stop pacing to the time the SA node recovered is called the SA node recovery time. Is that clear?
Yes, sir.
Okay, great.
No,
Now,
sir. No, sir.
okay, so we are pacing the patient, right? Right. So when you pace a patient, what will happen? You know, okay, so let's go to this place to make it clearer. So you see all this catheter, right? So we have a catheter in the HRA, ECS, right ventricle. We already told you that those catheter can detect conduction. So if electrical activity happens in the right ventricle now, the RV catheter will detect it. Abi? If conduction happens in the right atrium, RA catheter will detect it. Now, that's one function of this catheter. Another function of this catheter is that I can still program it to be pacing. So it can be pacing. So if I want to pace this patient's right atrium now, all I need to do is just stimulate it on the machine, and I will determine the rate at which I want to pace it, and I will start pacing. Okay? If I want to pace from the ventricle, I can pace from the ventricle with this catheter. All those ones are just on the machine. I'll just press it, pace, and I'll determine the rate at which I want to pace it. Abi? I can pace from the east, I can pace from the CS. Any of these catheter can pace. Any of these catheters can detect activity. Hope you get that, man. Now, the next thing is SA node. Let's take a patient, for instance, has a SA node firing at 100 beats per minute. Abi? So I want to determine the activity of that SA node. Is it dysfunctional or not? Because somebody has a heart rate of 100 beats per minute or 60 beats per minute does not mean that the SA node is not malfunctioning at some time or is not dysfunctional. So I want to test the integrity of that SA node. So how do I test it? The easiest way to test is that let me take his role. Let me use another person to subdue it. So you want to subdue a leader is to take his position, Abi, and say it's going to react. just like Lagos State Assembly. Don't recall that one. No? They took his position, so he reacted to take his position back. Abi, some of us know the news. People following Nigerian news. So apologies for that. So you take a presidential seat, the president has to fight back. Abi, so how do we take over the SA node function? Is to use another catheter that can be faster than the SA node. Abi? So all I need to do is I can use the HIV catheter, this catheter, any catheter. I already know that the patient is firing at a rate of 60 beats per minute. All I need to do is just come to the RV catheter and start pacing the person at 150 beats per minute. The SA node cannot fire up to that. So what will happen? That means that the person that is the pacemaker now is now the RV because it's the one I'm using to fire faster than the SA node. Abi? Is that clear? So that means that RV catheter that I'm using to pace the patient has suppressed the SA node because I'm pacing the right ventricle at 150 beats per minute. So that's the one determining the heart rate now. The SA node will have to go and be quiet because it was working at 100 beats per minute. I have subdued it by generating somebody else that is working at 150 beats per minute. So the question is, when I stop pacing the right ventricle, the heart will go asystole for a period. Abi? What should happen next? Then the SA node, which is faster than AV node, faster than EASE, faster than the Purkinje, should now fire faster than the others because I have stopped pacing that chamber or I've stopped pacing the patient. So the SA node should take over his role as the pacemaker. So the time interval it took between when I stopped pacing to the time interval that the SA node refires back, that time interval is called sinus node recovery time. It recovered its position back. Is that clear?
Yes, Prof.
Yes, sir.
Okay. Great. So that is what we are trying to just demonstrate on this EGM. That we're firing this time around on this EGM, HRA catheter is what was used. And it was firing faster than the baseline of the patient. So this is pacing spike, pacing spike, pacing spike, pacing spike. Now they stopped pacing here. Abi, you can't see a pacing spike here. So the time interval between the last time the patient was paced to the time interval you saw the SA node recover by the atrial activity, that time interval is the sinus node recovery time. If you calculate that duration on the machine, that's the sinus node recovery time. Hope that is clear. So, if that is clear, what we now said is that if the SA node recovery time is less than 1,500 from the slide we showed, we can say that it is normal. But if it's above 1,500, we can say it's abnormal. But we now give an exception to a caveat to that there are some people that their conditioned activity of their hearts does not reach the normal heart rate that you expect for them. So I said somebody can be a footballer. His heart rate will not be as 100 or 120 beats like somebody that is not doing any activity. That's not an athlete, I mean. So that kind of a patient, if his SA node recovery time is 1,800 or 2,000, that does not mean he has problem with his SA node though. Because we said that the longer the duration, the likelihood that there's a problem with that SA node to recover. So if you're having an SA node recovery time of 2,000, 3,000, can you say, it be like say, it looks like this SA node has a problem, right? Sorry about my colloquial language. so now, what I'm just trying to emphasize here is if you need to consider the baseline heart rate of the patient itself and now correct for the sinus node recovery time. So if I know the baseline of the patient, which we call the BCL, let me see if I have that BCL, baseline cycle length. So the cycle length, which is also called baseline cycle length. If I know a cycle length, I calculate this one. I was not pacing the patient, so I know his normal cycle length between one A wave to the next A wave, or between one P wave to the next P wave. I know that will tell me this resting heart rate. I will subtract it from the sinus node recovery time. Then I will get my corrected sinus node recovery time. So if I subtract sinus node recovery time from the normal baseline cycle length, if it is now more than 500, I can authoritatively say that this person either is an athlete or is anything. His corrected sinus node recovery time is problematic. He has a problem with his SA node function. Hope that is clear.
Yes, please.
Okay, great. So we can move on, Abi. So we can see how we can make diagnosis of SA node dysfunction. Any question on this? Okay, we'll move on. And we've already talked about how we make diagnosis of AV node dysfunction. If your AH is more prolonged than this duration, you will say that this patient has nodal AV node problem, AV node itself. If the HV interval is more than 55, you say that this patient has infranodal problem. Clear? Okay. If that is clear, we can now go to some EGMs. We've discussed this sinus node recovery time. And because of our time, how many minutes do we have left? So that we can go to the Brownward questions now. Okay.
So, Prof, you can continue. So, ideally, we have 1 hour more to our closing time. So,
Okay.
but I think it would be better for us to understand than to not
rush.
understand just to go and answer MCQ. So, I think, Prof, you can
Okay.
continue.
Okay. Don't worry. So even with this explanation self, we should have understood something. Okay. Good. I want to show us this EGM. It's a very important EGM. There's another thing we do on EGM. Let me see if I have it in the above slide. Sorry, I don't want to jump slides. Okay. Remember we said here that when you see S1, so let's look at something very clear here. This is one catheter represented here. The surface ECG, lead 1 and AVF, augmented limb lead. Abi? We have HRA catheter. So the only EGM we have is HRA catheter, right? And that is the only thing we're going to see. Basically, should be the A wave. Okay? Good. So that's what is in figure 1 and figure 2. So now, I want us to notice that you started pacing here because you can see your A waves, Abi? But you can see that your A wave changed here because you started pacing. Abi? So the wave will change if you start pacing. So that S1 you are talking about as is a cycle, is a pacing rate. Okay? So you are the one that will determine the pacing rate. So you can have pacing, you can pace consistently at a particular rate. So let's say patient is running at 100 beats per minute, you can start pacing the patient at 150 beats per minute, 180 beats per minute. Okay? So let's say you are pacing the patient at 150 beats per minute. So you are suppressing the SC node. So that means you are doing at S1, Abi? S1, 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 S1. Then you can stop. So at this place, you stopped. Then your duration between S1 and the natural AV node of the patient, atrial activity of the patient, A wave, is the sinus node recovery time. We've discussed that. Now, there are times that you can initiate another pacing on that rate. Remember, you were pacing consistently at what? 150 beats per minute. I can add another premature beat in the pacing on the machine, and that premature beat can now give me a rate at 180 beats per minute. If you notice, I entirely avoided using some word milliseconds. The reason is because I don't want to confuse you between milliseconds and beats per minute. I know that if I talk about beats per minute, you understand better than me talking about 100 milliseconds, 1000 milliseconds. You get what I mean? So let me talk about beats per minute so that to make it clearer. So as I said, I started pacing this patient at 150 beats per minute. I stopped here. But sometimes I might not stop. I will just add another ectopic beat which will come at maybe 180 beats per minute. Remember, we said we're pacing him at 150 beats per minute. If I added on top of that 150 beats per minute an ectopic beat at 180 beats per minute, I will call that ectopic beat S2. Do we get that? So that's what we call extra stimulus. Extra stimulus. Okay? Or a single extra. Now, that is so the S2 is the extra stimulus. Now, I can also determine, remember the S2, I brought it at 180 beats per minute. Then I can also determine to add another rate at 200 beats per minute on top of that 180 beats per minute. I will call that one S3. Why am I saying this? So that when we are looking at an EGM and they write S1, S2, S3, you can know the meaning. S1 means that the pacing rate at which you started is different from the baseline of the patient. We are pacing the patient now. So the base pacing rate at which you started, example, you can start at 150 beats per minute. But I want to make it faster or introduce an ectopic beat. The purpose of all these ectopic beats is that you want to initiate a tachyarrhythmia. You want to start the reentrant tachycardia. Since we understand the physiology of what we talked about reentrant tachycardia, it's ectopic beat that generates that reentrant tachycardia. So I want to be initiating some ectopic beats that can capture and enter into a reentrant tachycardia and start generating the tachycardia. So that means that I will be selecting faster rates to generate an ectopic beat faster than the rate I'm actually pacing the patient. So I can come with S2, which will come at 170 beats per minute. I can come with S3, which will come at 200 beats per minute. You get like that. So I can be changing the beat rate. So that's the meaning of if you see S1, S2, S3, they are just different rates, faster rates than what you started with. Is that clear? So that brings us to this now. You can see this. Look at the time interval. As I said, S1 means you have started pacing the patient. So you started pacing with patient S1 at a particular rate, let's say 150 beats per minute. So that means between here and here is 150 beats per minute. You get that. So now you can now introduce something shorter, faster. That will be the S2. That can be 180 beats per minute. You can now also introduce another S3 faster than the S2 at 200 beats per minute, so that you can understand when they use the word S1, S2, S3 on EGM. Hope that is clear. Dr. Eugene. Hope I'm still audible.
Yes, please. You are still audible.
Hope people are not sleeping. Okay, because I can see that the
We are awake,
participant
sir.
is
It's clear, Prof.
time to 38.
Prof,
Okay.
thank you. Prof, please, I didn't get it. S1, S2,
We are with you, sir.
Okay.
Prof, I didn't understand, please.
Prof, I want to. Okay.
Yes, I will explain. Yeah, someone wants to ask a question too.
Prof, sir, I also wanted to ask, why are you putting what does the electrophysiologist want to achieve
Yes.
by
Fantastic. Putting
S2,
S2.
S3 especially?
Fantastic. Yes,
Yes.
you are very correct. I will tell you. I will tell you. Okay. So let me start first explaining the S1, S2 for our colleagues so that you will get that. Then we'll not tell you why we are doing it. Abi? Great. So let's look at this patient very well. This is an EGM, Abi. So you can see is normal HRA activity, A wave, right? You can see the shape. This is when he's in own sinus rhythm, PQRS T, Abi, PQRS T. You are not pacing this patient. So it's his own sinus rhythm, normal A. You didn't pace the patient. Abi. But look at S1. That means that, remember we said those catheter can detect and also pace, Abi? So we've started using that same HRA catheter to start pacing this patient. Do you see that? S1. You can see that this A wave is different from this S1. That means you have started pacing this patient. So the same way you look at an ECG. ECG of a paced beat is different from ECG of a normal sinus rhythm. Abi? when the patient has a pacemaker. Abi? So you can see you started pacing this patient, and I said we just theoretically said, oh, let's say we are pacing this patient at 150 beats per minute. So you started pacing at 150 beats per minute. So all your S1 you're seeing is that you are pacing the patient at what? 150 beats per minute. So if you continue at this figure 2, you will still pacing at 150 beats per minute. But in this representation, they stopped pacing the patient, and the patient came back to his normal sinus reading back. A wave, A wave. Is this one clear, sir?
Yes, please.
Good.
Yes, sir.
Good. Now, the next thing we want to do is that, can I pace this person? Remember, I started pacing this patient at 150 beats per minute. I want to generate arrhythmia. So I want to increase the rate at which I'm pacing this patient. So instead of this 150 beats per minute, I want to make it faster to 180 beats per minute. If I want to do that, I don't need to stop pacing and start pacing again at 180 beats per minute. I can add that 180 beats per minute on this 150 beats per minute. Do you get that, sir? And you now make it 180 beats per minute. Bam, bam, bam. Faster than this 160 beats and 150 beats per minute. So to separate 150 beats per minute from 180 beats per minute, I will call that one S2. Do you get that, sir?
Yes,
Doc-
Prof.
Good. I want to be sure Dr. Onwuda gets it. Okay?
Prof.
Did you get that, sir? I
Yes,
need to be
Prof.
sure. Okay, good. So that means I don't need to stop the 150 beats per minute. I want to just make it faster. I'll just increase the rate to 180 beats per minute. So that means if to mathematically separate them, I need to be sure which one I was doing at 150 beats per minute and the one I was doing at 180 beats per minute. Right? The same thing, that 180 beats per minute, I can increase it to 200 beats per minute. That means that I will need to separate S2 of 180 beats per minute from 200 beats per minute. So I'll have to call that 200 beats per minute S3. Do you get that, sir? So your S1 simply means the pacing rate at which you started. Your S2 means that the extra stimulus you added to make it faster than the S1. And the S3 means that you also augmented it again faster than the S2. Is that clear, sir? And so that means that your S2 will not be an ectopic. You know, when we're looking at ECG, when we say ectopic means that it came before its time. Abi? So S2 will be an ectopic, S3 will be another extra ectopic on the ectopic. You get? So question asked as, why are we doing this? Okay, there's a reason why we are doing this. So first, I hope we can now understand S1, S2 now, the difference. So if you look at the time interval between these S1s, Abi, you can see it's different from the time interval is shorter between S1 and S2 now because the rate is faster. Hope you get that. That means if I have an S3 now, it will be even far shorter than between S1 and S2. Is that clear? Okay. So what we now need to do is why are we doing this extra stimulus? It's very simple. It came from our normal reentrant tachycardia that we know about. Remember we talked about this reentrant tachycardia. Most patients have dual pathway on their AV node, Abi? But most of the time, one of the pathway is inactive because it's a slow pathway, Abi? And as we explained that when electrical activity comes from the atrium, it will pass into both pathways, Abi? But because the faster pathway will be faster than the slow pathway and to get to the ventricle, by the time the slow pathway is bringing conduction, that activity is blocked, right? Because this slow fiber is slower in conducting, but has shorter refractory period. Good. So imagine this patient is running at 60 beats per minute. It's not going to have arrhythmia because its faster pathway is fast, has slower, has longer refractory period. So anytime the slow pathway is bringing conduction, it's in its absolute refractory period. So it won't allow conduction. So it is blocked. But question is, what if premature beat enters? Premature beat now enters. Bam. It now enters into the slow pathway, and the slow pathway conducted downwards and entered when the fast pathway is already in its relative refractory period. So relative refractory period means that the time is the period where you can still stimulate. If you generate enough threshold, you can stimulate the tissue for action potential, and it will depolarize that tissue. So it means that a premature beat came in, and that was what now made this slow pathway to conduct. And now the fast pathway has received the conduction retrogradely. Do you get that now? And that circuit will now continue because as the fast pathway is getting up, the slow pathway is now it has shorter refractory period. So by the time the fast pathway is taking the pathway upward back, it can enter the slow pathway easily because it has shorter refractory period. It will just enter it, and the entrant tachycardia will happen. Do you get that, sir? What caused that reentrant tachycardia was a premature beat. True or false? It's a premature beat, Nabi. That's what we studied when we were doing this. I guess someone took this lecture, right?
Yes,
Dr.
sir.
Eden.
Someone did.
So
Yeah.
it was, yes, so it was a premature beat. So that is what we are trying to stimulate when we are doing that S1, S2, S3. We are trying to stimulate a premature beat that will enter into that tract and generate the tachycardia. Do you get that now, sir?
Yes, Prof.
Okay, great. So anytime we are doing, so anytime we are pacing, what we are trying to do is we want to induce the arrhythmia. So it's induction. There are two ways of inducing arrhythmia in the EP lab. One, by doing pacing, direct pacing, or by giving pharmacological agents. Isoprenaline most of the time, but you can use dobutamine or dopamine. But most of the time, isoprenaline. You just want to stimulate tachycardia so that the arrhythmia will happen. Then you can now use your catheter to know the location of where the arrhythmia is taking off. Do you get that, sir? So the whole purpose of pacing is to generate that circuit and stimulate the arrhythmia. Hope that's clear, sir. Is that clear,
It's
sir?
clear, sir. It's clear, sir.
Okay, good. So let's see something here now. Just to buttress the fact that you can have an S1. So you can see that for this EGM now, this patient is paced at the HRA. Why? Because in that its shape is different, and they labeled it for you to make it clearer for you. Okay. So you can see they were pacing at S1, S1, S1. Then later, the pace rate was increased. Abi? Because if you look at the time interval between year and year, it's longer than the time interval between the S1 and the S2. So that means between the S1 and the S2, the time interval is shorter because the S2 rate is faster than the S1 rate. Hope we get that, sir.
Yes, sir.
Okay,
Yes,
great.
sir.
So, good. So, when they stopped pacing, so the S2 they give was just faster one beat. You can see just one S2 beat, faster than the S1 beat. And they stopped, and you can see the patient recovered his electrical activity back. So let's trace this EGM, I mean, sorry. So this EGM, let's start from the last EGM here. So we can see HRA catheter, right? Is the first catheter. You can see the RV. They gave us lead 1 AVF V1. They gave us RV catheter, EGM, HRA, East distal. I told you also where distal is. East proximal. They gave us CS1 to 10, right? So if we look at this patient now, they started pacing S1, right? So they were pacing from which catheter? HRA catheter, right? From the right atrium. S1, S1, S2, right? When they stopped, you will see his normal, patient normal A wave came up, right? So the normal A wave coming up. Excuse me, just a second. So the A wave now coming up, you can trace the same A wave in other catheters that can give you that A wave. Abi, we said your East catheter can give you A wave, H wave, and V wave. Abi, so we can see our A wave in the East catheter. You can see the H wave in the distal East and the V wave because it bridges atrium to ventricle, right? We can see our CS catheter, right? So CS catheter, we said will bridge the distal end will bridge more of the left atrium, proximal end will bridge more of the right atrium, and the far end will also bridge the left ventricle. So that's why you can see two waves, Abi, atrial A waves and V waves, Abi, for the CS catheters. Hope that's clear. And you can see the RV deflection, just focusing on the RV. So if you look at this patient's normal recovery time now, pace the SA node recovered, so we can see the HRA giving us the deflection in the right atrium, followed by the A wave in the East catheter. You can now see the A wave in the CS9 and 10 came first, Abi, compared to CS1 and 2. Dr. Eugene, is this clear to you, sir? So you can see 9 and 10 is earlier than 1 and 2.
Yes, sir.
Okay. It's clear, Abi?
It's clear, sir.
Now, let's see when they were pacing this patient. They were pacing from HRA, Abi. So if you are pacing from the right atrium, that means that the conduction will come to the right, depolarize the right atrium first before the left atrium. True or false?
True.
True, Abi? Good. So we can now see that when they paste S1 now, you can see your CS9 and 10, Abi, was earlier than CS1 and 2. Can you see it now?
Yes, sir.
So this is very important why I'm showing us all this, because if you see CS1 and 2 faster than CS9 and 10, it tells you that the generator is close to CS1 and 2. Do you get that?
Yes, sir.
So that is why anytime you are doing EP, please let them give you your CS9, 1 to 10, if you are going to make a proper diagnosis. Are we getting it, sir? So
Yes, sir.
imagine they paste and you did not see HV activity. You didn't see R wave. They paste, you saw atrial activity, but you didn't see ventricular activity. So let's just complete this thing we have. So you saw the paste S1, you can see A wave, Abi. Let's focus on the East catheter now. You can see A wave on the East catheter. You can see the East spike. So we can calculate AH, and we can see the V. We can see the HV. Abi? Are we getting it?
Yes, sir.
If when they increase the pacing rate to S2, you can still see the A activity in the East catheter, H activity, and the V2 activity. Abi? Good. So what we are saying here is that imagine they paced and you only saw A activity because they paced from the atrium. You saw only the atrial activity and you didn't see V. What would that tell you? That means that there is a block in the what? AV node. Because that means that you didn't get to the ventricle. True or false?
True.
Okay. So we can understand we make diagnosis. That's what I'm saying. So, okay, good. So this is what you expect normally in a normal reading, and in a paced reading, this is what you expect. It should still, CS9 and 10 should be earlier than CS1 and 2. Okay? And you should see all your waves complete on the East catheter, A, H, and V. So if you see only A and you didn't see V, there's a problem with the bundle. Abi, AV node and bundle. That means that the thing did not conduct to the ventricle. Okay, so can we move on?
Yes, please.
Okay, good. So we move on. So we have the next thing here is that they paste. So let's study this thing very well. They gave us the surface ECG, abi, lead 1, AVF, and V1. They gave us R wave. Sorry, R catheter, RV catheter. So there's a catheter in the right ventricle. There's a catheter in the right atrium. East catheter is there, abi. Then you have your CS 1 to 10. Good. Hmm. So I want us to see something. No? Very, very well. So 9 and 10. So I want us to also remember something, that when you are looking at A waves, we know that HRA will give you A wave, right? East catheter will give you A wave. And just like you have, HRA is giving you A wave, East catheter A waves, CS will give you A waves. Good. One important thing is that which catheter is closer to the SA node? So if the impulse is coming from the SA node, right? So the catheter closer to the SA node should be faster to deflect, abi, before the catheter away from the SA node. So if your HRA catheter is closer to the SA node, that should be give you your first deflection. True or false?
True.
Okay, good.
True.
So that means that if there's another area that is deflecting before the HRA, then it tells you that that's where the problem is now. Because you expect that conduction should come from the SA node before it gets to the AV, or before it gets to the lower right atrium, before it gets to the left atrium. But if conduction is getting, if the conduction is starting from the lower right atrium, that means that it tells you that that's where the arrhythmia is coming from. Abi? So
Yes.
let's see something here. Let's show us something. Let me show us something here. In this slide, after they stopped pacing at S2, what happened? SA node recovered, Abi?
Yeah.
And it conducted down to the east, to the left atrium, and things like that, Abi, following this trajectory, right? You can see
Yes.
that trajectory. So this is what you call concentric pattern. Concentric pattern. That's the trajectory from the high right atrium down to the left lateral wall of the left atrium. That's what you call concentric. So you can see the person that started it first is the high right atrium because it's closer to the what? SA node. Abi? Are we
Yes.
getting it, sir?
Yes, sir.
Remember they stopped pacing here. So that is why we could monitor this. Now, let's look at the second slide. They also paced, Abi. Look at the second slide now. S1, they paced, and they stopped pacing at the S2, Abi. You cannot see any more S, Abi. So that means we expect that this should be the recovery time of the patient's native activity because they didn't pace these beats, Abi.
Yes, sir.
So the question you ask yourself now, look at the HRA. Look at the CS catheter. So tell me who was coming first? Is it the HRA or the CS catheter?
The CS
Yes.
catheter.
Is it CS?
10.
So you can now see that
CS 9 and 10.
exactly. You can now see that the patient's problem, his pacemaker is not the SA node. His pacemaker is in his CS 9 and 10. That's lower right atrium. That's where his aberrant tract is coming from. Do you get that now?
Okay, so Prof, that's why his bundle proximal picked it up early, even before. Because if you look at
Yes,
the proximal, that's also coming before the high
it's
right.
coming before now because your 9 and 10 is closer to where? The CS orifice, Abi?
Yes.
And CS orifice is closer to where which node is there? AV node.
Yeah.
Abi, so which catheter will pick it first? If that is where it's generating the pacemaker, the East catheter or the HRA catheter? Do you get my question now?
Yeah, I understand.
Yeah, it's his catheter that will pick it first.
Exactly. So you cannot see the reason. So you can see the reason why you need to understand the rhythm of how the waves are meant to come. So this is an eccentric pattern. It's not coming from top to bottom. Rather, it's coming from top, bottom, top approach. Do we get that, sir?
Yes.
It's clear, Abby? So the same reason, if the CS1 and 2 is earlier than HRA, it tells you that that's where this problem is coming from. So you can now see the importance of the waves and the catheters, what they do. Are we getting it now?
Yes, sir.
So now, what is the importance of doing S1, S2? Because on a normal day, if the patient is in a sinus rhythm, that means the SA node is the one taking over, Abi. You will not see any arrhythmia, Abi. But if you induce the tachycardia, which they did with the S1, S2, and they induced the tachycardia, they now found out that the person that is now, when they stopped the tachycardia, the person that took over, that is now the rhythm changer, was now lower right atrium. So it tells you that his aberrant tract or accessory pathway is closer to his lower right atrium there. Do you get that now, sir? Because that's the rhythm changer when they stop the tachycardia. Hope we get it, sir. Do you have any question on this, sir? Hello,
Yes.
Dr. Eugene.
Prof, we are audible.
I want to be sure if this is clear.
I think it's clear. I believe if it's not, my colleague should respond. It's clear.
So if there's any question, they can ask me now, so that, and that's why I don't want like taking a lot of time, so that people will not sleep. Now, so one important thing we are trying to emphasize is that if the patient is in normal sinus rhythm, you might not see this abnormality. But when you induce the tachycardia and you stop it, the person that is mediating that tachycardia will show face. And that's why you know that, okay, this is where the accessory pathway is. So if they're going to ablate, they will ablate around that accessory pathway. So that means if you're going to ablate now, you ablate around the CS orifice, close to the AV node. You can see how close that tract is to the AV node. So this is still AV. This is still what Parkinson White because it's not nodal reentrant tachycardia. If it's nodal reentrant tachycardia, we said all the activation will happen on a straight line. So this is still AV reentrant tachycardia, but close to the AV node. Because you can see CS9 and 10 is the earliest activation, followed by the east bundle area. You get? So the patient you say has a Parisian tract, just close to the east. Is that clear, sir?
Yes, sir.
So anytime you're looking at the waves, don't be confused at all. Just know RV, how many waves are you supposed to give us? One. Boom. HRA, how many waves are you supposed to give us? One. Boom. CS, you're supposed to give us two. Left atrium, depending on the location, and the lateral and the left ventricle. Abi? East catheter, you're supposed to give us three. Abi? A, H, V. Abi? So if you are seeing many deflections, because this one you are seeing now, where my arrow is, it's just spacing spike. So don't think it's a wave. Just look at the catheter. What is it supposed to produce? This catheter is labeled as this catheter and it's supposed to produce so waves. If it's East catheter, you're supposed to produce E3 waves, A, H, V. If you are CS catheter, 2 waves, A and V. If you are RV catheter, 1 wave. HRA catheter, 1 wave. Hope it's clear. So by the time you now start analyzing the waves, it will be easier for you. You will not be getting confused with some deflections. Because this deflection you are seeing is actually a pacing spike. Because some people, I'm sure, will be looking at, what was this deflection again? Which one is this? Which wave is this? You will get confused. Just look at the catheter and what are the waves you are expecting from that catheter. Any other thing you are seeing is either an artifact or a pacing spike. Is it clear?
Yes, sir.
Good. So as we progress, can we move on now?
Yes, please.
So let's look at this patient very well. It's not hard. It's not hard. So let's look at this patient. They gave us our leads, Abi, surface ECG as usual. They gave us the RV, right? They gave us HRA, distal east, proximal east. We already said we should know the number of waves they're expecting on the east, Abi. 3 waves, AHV, straight. And they'll be distinct and they will correspond with their surface ECG. The V wave of the east catheter will correspond with the QRS, Abi. The A wave on the east catheter will correspond with the P wave, Abi, on the surface ECG. So there's no hassle. Then if you CS catheter, I'm only expecting 2 waves. The A wave and the V wave. The V wave will correspond to QRS. A wave will get close to the P wave. I mean, say just so any other deflection you're seeing, you're just playing there. You don't need them. Okay. Now, so let's sit down and see what happened. What did they do for these patients? Seeing this big pacing spike, they've already started pacing it S1. They've told us, Abi, this wave is not different from this wave. Abi, but you know that it is different from this last wave. Abi, hope I'm audible.
Yes,
So,
Prof. It's audible.
yeah, great.
Yes.
Fantastic. So you can now see that this is an A wave. Where my arrow is now is an A wave. It's different from pacing wave. Abi? So that means if they didn't pace this patient, this was the necessary HRA wave I should be seeing. The wave I'll be seeing on the HRA, this will be the A wave. That's the shape. Hope we clear. Abi? And you can see the concentric pattern in the sense that after the HRA wave that came first, you saw the east wave coming next, Abi. Then you now saw CS9 and 10 coming before CS1 and 2. Is it clear? So you expect that this is a normal conduction of the atrial activation. True or false?
True.
Okay, great. Thank you. Thank you, sir. So there's no problem with this one. Okay, so let's see. Where is the problem? In this, the next after the A wave, we saw the E spike, Abi. So I can measure my HV duration, Abi, AH duration and HV duration.
Yeah.
Then I can see my R wave, Abi, the right ventricle wave, which corresponds to QRS. I can see the V wave in the east catheter, Abi, which also corresponds to the QRS. I can see the V wave in the CS catheter, Abi, we also correspond to the what? QRS. It's clear, Abi?
Yes, sir.
So it's only the east catheter that will give me A, H, and V. So there's no confusion here. Abi? Good. So let's go and analyze the wave from the beginning. I already know that this HRA, this wave I'm seeing, that's A wave, is not a normal A wave. It's spaced A wave. Abi? Because I've seen the normal at the end. True or false? Good. So that means they paced S1, 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 they label it for me S2. So if I see the time interval between the S1s, it is constant, Abi. But that between S1 and S2 was shorter, Abi. So that means that S2 is an extra stimulus. Are we following? Are we together, sir?
Yes, sir.
Good. So extra stimulus S2. Okay, good. So let's continue. When they paste the S1 at the HRA, I can see my P wave deflection in the east catheter coming before the CS9 and 10, Abi, and down to CS1 and 2. I can see my east spike. I can see my V wave on the east, Abi. So that means I can measure my AH and HV. I can see the other V's in the CS catheters, Abi. The next S1 pacing is the same thing. I measure my AH and HV. I will compare it to where I started from. Is the distance changing or not? Is so as to test the decremental property of the AV node. Because sometimes in a patient that has atrial fibrillation now, you know that you can have very multiple atrial activity, but the AV node will block a lot, Abi, for mentoring. So that means as the AV node is blocking, the conduction time will be getting longer on the AV node. The faster you pace the atrium, the longer the conduction time in the AV node will be taking. So that's the decremental property of the AV node, just to block the number of waves that gets to the ventricle. Abi? Good. So that is why I measure my AH and HV and see, is it getting longer? Are we getting it? The
Yes,
next
Prof.
time, good. So they paste another S1 again. That means they paste at the same interval. Maybe they were pasting at 150 beats. So the same S1 are always 150 beats, if that was what they selected. Abi? Good. So I saw my A on the East catheter. I saw my H. I saw my V on the East catheter. Abi? True or false?
True,
True,
Prof.
sir.
True,
True.
So
Prof.
that means good.
True,
So
sir.
that means that from this S1, no, this S1 I'm seeing, I can see the A on the East catheter. That's why they call it A1. I can see my H1 on the because it's related to this S1. And I can see my V1. Abi? It's clear. Abi? Good.
Yes, sir.
Now they now gave an extra boost, S2, bam. So I saw some fragments on my, you can even say I'm not seeing much on my East catheter, but I can see at the East proximal, I saw a wave, Abi,
Yes, sir.
on East proximal. So that's, I can call that one A2, Abi. The CS catheter 2 follow the same, Abi, CS 9 and 10, Abi. Are you getting it?
Yeah.
Next question, what should I expect next?
And H2.
Did you see? I know see. After H2, what are you supposed to see again?
V2.
Did you see? Did
No.
you see any QRS related to that surface ECG?
No.
So what has that told you?
It means that you're not having conduction from the atrium to the his bundle.
Exactly. So that tells you that there's an AV block. Do you get that, sir?
Yes, sir.
Is this clear, sir?
Yes, sir.
You know why I'm pushing this to us, sir? So that sometimes, let's say we didn't pace this patient. Imagine that we didn't do S1, S2, S1 and S2, and we see this normal EGM. Then we got to this place, we didn't see an EGM again. What diagnosis has that made for us? It's an AV block diagnosis now, Abi.
Yes, sir.
Do you get that, sir? So you can see how easy it is to use your EGM to make a diagnosis. Just follow the expected tracing. It's clear, right?
Yes, sir.
Because now
Sir,
after the recovery, yes, just 1 second, sir.
so,
So after the recovery, just 1 second, sir. So after the recovery now, you can now see the A wave, Abi. You can see the East, Abi. Then you can see the V wave. So the question is, where is the East and the V wave in this after this S2? So you can ask your question, sir.
sorry, sir. I don't know. With this, since it's distal, can we see from this that it's infranodal from this
Okay.
tracing, sir?
Okay, great. I'll answer your question. So the reason why we cannot say that yet is that remember you will paste the patient. And I told you that's why I give us an example that let's say somebody has atrial fibrillation. Not all the waves coming from the atrium will pass through the AV node. Abi? AV node will naturally try to block. Abi? So it's because this was paced. Imagine it was not paced. Let's say it was not paced. Now we can say that below this thing did not conduct below the AV node. You get what I mean? So we'll be suspecting a infranodal block. Do you get that?
Yes,
But
Prof.
we show you a pure nodal and infranodal. We'll show you. But because this one was spaced, that's why we can't just beat our chest and say, we just know that this one shows that the faster the heart rate, the AV node blocked a very fast heart rate coming from the atrium. So this is testing the integrity of the AV node to block excess wave coming. Remember, they were pacing it. So they will now get something very faster again. So the AV node have to block it and say, come on, get out of there. So it tells you that the AV node can block. So that is what was tested here because it was spaced. Do you get it, sir? That's why I use the example of an atrial fibrillation.
Yes, sir. Thank you, Prof.
Okay. Do you have any more questions on this? Can we move on?
Yes, Prof.
Okay.
So, hello, sir.
Yes, tell me. On that
So,
first
Prof,
one.
sir, yes, sir. This is used to test the integrity of the AV node. That's what we are trying to
AV
test
node. Exactly. Test the integrity of AV node. You get what I mean? So when you
Yes, sir.
do, so remember when we started, we said we tested the integrity of the SA node, Abi?
Yes.
So the next thing to test is to test the integrity of the AV node. Before you start jumping to be looking for where the tract is, and you get first test their integrity to be sure are they dysfunctional or normal. You get if you are passing many waves up to 200 beats per minute, let's say we are passing at 200, 250 beats per minute, and everything is getting to the ventricle, then it tells us that there's a problem with that AV node. Though. It's not blocking things. You get what I mean? So it's either it has a tract close to it, but it just tells you that there's somebody that is taking over the function of that AV node that's not making it to block. You get what I mean, sir? Because let's imagine, sir. I want you to imagine. Let's go back to this reentrant tachycardia. So let's go back to this. So let's say we are pacing on the right atrium. HRE catheter is up here. So I'm pacing at 160 beats per minute. Later, increase it 200 beats per minute. I will expect that not all the 200 beats per minute should pass through the AV node and block and get to the ventricle. Abi, AV node should block some. Now, so if the AV node is not blocking, I went to 200 beats per minute, is not blocking, 250 beats per minute is not blocking, 300 beats per minute, then it tells you that somebody else is passing that tract down there. So that's another way of making diagnosis of what? A bypass tract. That it seems this thing I'm pushing down is not truly passing through the good AV node. Somebody else. Either the tract is close to the AV node or the tract is away from the AV node and is passing everything I'm passing down and is active. Because a bypass tract, even if you give 400 beats per minute, it will pass it. It has very short refractory period. If you give 500 beats per minute, it will pass the thing. You get what I mean? And you know that AV node, no, if a AV node is in its right sense, it cannot pass more than, in fact, it should not pass up to 200 beats per minute to the ventricle. So if we are stimulating at 300 beats per minute and everything is getting to the ventricle, there's somebody that is bypassing the AV node. Do you get that, sir? So that's another way of letting you know that it be like say there's an accessory pathway somewhere. Do you get it, Chief Okore?
Yes, Prof. It's clear. Very clear.
Okay. Okay, great. So I think with this, so as not to now another thing I want to bring to our attention, sir. Remember, I said that we can pace the heart from any chamber. Abi? Do we get that?
Yes,
Remember,
sir.
we said those catheters, they can sense and they can pace. The ones we've shown above are pacing from the right atrium. Are we getting it? The question is, so all these ones, they pace from HRA. Huh? Are we getting it? That's from the right atrium. We can also pace from the east bundle. We can also pace from the ventricle. Are we getting it? We can pace from the CS catheter. So let's imagine now we pace from the ventricle. So that is where you now talk about VA conduction because you are pacing from the ventricle now. So you'll be conducting from the ventricle to the atrium. So now with this image beside this EGM, you can see that the pacing spike threshold has been drawn in the ventricle. So they are pacing now from bottom top approach. So you are pacing from the ventricle to the atrium. You see that? So you're talking about VA conduction. And that's why you should understand that your your conducting fibers can conduct both antegrade from atrium to the ventricle and can also conduct from ventricle to the atrium. Do you get that? So they can conduct in both directions. It's just like your electricity wire. If you plug one end to the electricity and plug another end and touch the other end, electricity will conduct. Even if you now change it the other way around, the one you are holding, you plug the wire now to the socket and you're now holding the other end that you plugged before, it will still conduct. True or false? Do you get my analogy, sir?
Yes, sir.
So you have one wire now. You plugged, we're holding end A. You have end A and end B. End B, you connected it to the socket and you're holding end A. Will it shock or it will not shock when you bring on the light? It will shock you now, Abby. Now, change it back again. So now take end B, hold it, and that end A you were holding before, plug it to the socket. And you want the socket. Will it shock you or it won't shock you? Professor Eugene.
Hello, Prof. Please, I lost you briefly.
Okay. Is my network audible now?
Yeah, you are audible. I got
So I'm
distracted briefly, so it wasn't your network, please.
okay. So what I'm trying to emphasize is that you have a wire, you have end A, you have end B. You label it end A and end B. You know the two ends of the wire, A and B. You plug B to the socket, and you switch on the socket, and you are holding end A. The conduction will happen, Abi. It will shock the
Yes.
person holding the naked wire.
Yes, sir.
Now, remove end B that was plugged before, hold it, and that end A you were holding before, connect it to the electricity, and hold end B. Will it shock or it won't shock?
It will shock you.
Exactly. So meaning that our conducting fibers can conduct in both directions, from top to down and from down to top. Do you get that?
Yes,
So
sir.
that's why we can talk about VA conduction. Okay. So that means if we pace from the ventricle now, it can conduct to the atrium. Hope we get it.
Yes, sir.
So for this now, they gave us the EGM, so the surface ECG and the EGM, the same EGM of RV being top to down. But you can see that our S1 is now labeled at RV. So that means they are pacing from the RV top. Okay. So if you are pacing from the RV now, that means you will see a VA conduction. That means ventricle before atrium. We get that? So it's coming from ventricle first, then the proximal is first before the last part of the HRA, because you can see the direction of the conduction. Because now we are pacing from the apex of the right ventricle. Do we see that now? So I will expect that my East, A at the East and CS 9 and 10 will come before HRA. True or false? Chief Okoye, don't get tired.
Prof, we are
Am I still
still.
audible?
Yeah, you're very
It's you.
audible.
Well with you, sir. It's true.
It's true. Should we round off? You bless me, you are tired. Should we continue or should we round up here?
Prof, I think you can
Let's
conclude
continue,
the
sir.
atrial excitation, yes, sir.
Okay, good. So what I'm just trying to emphasize is that if you pace from the ventricle with this image diagram down to the atrium, the lower atrium will depolarize first before the upper atrium, right? So that means your CS9 and 10 and the East A will deflect before the HRA that is close to the SA node. True or false, sir?
True.
Yeah, so that's what you are seeing represented on this EGM. So you see S1 is from the ventricle now. Pacing spike is from the ventricle. So you expect that East catheter deflection would happen. Remember, it's V first, VA. You are conducting from V to the A. So you see your V, then your A. But what I'm trying to emphasize is that your A now will be earliest at the East and CS9 and 10 before HRA.
Yes, it makes sense.
You get that? So it just tell you that this is a normal conduction. from VA conduction. Unlike if it was from atrium to ventricle conduction, it would be other way around. Abi? Any
Yes, sir.
question on this?
So, Prof, if it's coming from the ventricles before it goes to the atrium, why aren't we seeing the H from the His bundle tracing?
No. So you can actually see the H. This one is just fragmented. They're fragmented. You can actually see the H. You
Oh,
get.
okay.
So the E spike. So also just remember that E spike sometimes it can be merged into your EGM in the East catheter because it depends on how the person placed the catheter, how it is touching the East itself. She get, but you're expected to see it. Okay, but one beautiful thing is that the faster you also pace, the more narrower your complex your EGMs will be. Okay, so but your East catheter can show even from a VA conduction. Okay, I will show us some other images that we have. It will show. You get, so I don't think that's a problem at all. So, but what we should understand is how the deflections will happen. Who is going to deflect last? If you are pacing from the right ventricle, who is meant to deflect last? And if you are pacing from the right atrium, who is meant to deflect last? You need to understand that deflection pattern. Okay. Any questions, sir? Okay, so I think we can now go to the. Do you want us to take the Brownward questions now, or
We, per our time of closing, we still have time. We still have 11 minutes more. So I
okay?
think
So we can
we
quickly
can
take it.
take, yes.
Okay, so let me bring up the Brownward. Just a second. Okay, so let's so we'll first go to the ones that have deflection. That's question number 3. Waiting again, sir. I know you sent it to me. Let me check. So we'll still continue EP later, but I just want us to at least apply what we've learned first to
Okay.
question 3 what?
So we have
With this little knowledge, you should be able to answer these questions.
356, 372, but I will have to trust. Let me just.
3, 5, 6. Okay, I'm going to share my slide. So
Okay.
I just want to get to the question first. 3, 5. 3. Okay, I'll share the slide now. So 3, 5, 6, I mean.
Yeah, we had 356.
Is
We
this screen
also
right?
had 366, 367. So I'm trying to get to the 356 to see what was there.
No, can you see my screen? Am I audible?
Yes, Prof, we can
Yes,
see.
Prof, we
Yeah,
can
Because
see
you should
it.
be able to see my screen so
yeah,
that
we are seeing it.
you won't waste time. So this 3, 5, 6, I mean. Good.
Yes.
So each of the following statements about invasive cardiac electrophysiology study is true, except so of the common arrhythmic causes of syncope, tachyarrhythmias are most reliably initiated in the electrophysiology lab, followed by sinus node abnormality and East Purkinje block. True of us. With all we've said, they are looking for excepts.
The statement is true, sir.
Exactly. Okay, good. So supraventricular. So what they are trying to say is that okay, patients that have syncope from that most likely syncope can be caused by tachyarrhythmias. Maybe somebody has what Parkinson White and all that. But you can make a reliable diagnosis with EP and also test the function of the SA node. and the AV system too. That's what we've discussed now, right? So I guess that statement should be true. Are we
Yes,
getting
sir.
it, sir? Good. So supraventricular so option B, supraventricular tachycardias are characterized by a east ventricular interval that is shorter than that recorded during normal sinus reading. So what did we say?
That one should be false.
That statement is also true, sir.
Because somebody, remember, what did we say about duration and heartbeat? So we said that the longer the duration,
Shorter.
those intervals, so that means that if you are having longer duration, it should be having slower heart rate. Abi? So that means that if let's say your sinus baseline cycle length is getting to, it's supposed to be 300 to 800. Let's say you are getting to 1005, 2000. That means your heart rate will be going from 60 to 40 beats per minute, 30 beats per minute. So the longer the interval, the slower the heart rate. Abi?
Yes,
So
yes.
that means that the shorter the interval, the faster the heart rate. Do we get that, sir? I hope we got that. We said the longer the interval. So baseline cycle length. If you're having a baseline cycle, should I go back to our slide again on? I think I have it and I didn't close it. Sorry. Yeah, you can still see my screen, Abby.
Yes, Prof, we can still see it.
So let me go back to this baseline cycle length. So I want you to see this, sir. This baseline cycle length, BCL. If you have we said the normal baseline cycle length should be 300 to 800, I mean. So
Yes, sir.
baseline cycle length 300 to 800. So look at, that means one heartbeat is about 800 milliseconds. Abi? One heartbeat. Abi?
Yes.
If I increase this milliseconds to 2000, that means that I've prolonged this cycle length, Abi. So
Yes.
that one heartbeat is 800 cycle length, 800 milliseconds. If the person now has 1000, so that means if he has 60 heartbeats, we want to just do it mathematics. One heartbeat, 800 basic cycle length. So 60 heartbeats. What do you think will be the basic cycle length? Or the math look complex? It's not complex. So what we're trying to emphasize is that if I'm going to get between P wave to the next P wave is 800 cycle length. If I increase the cycle length to 2000, that means it's going to also it's going to take longer to get one cycle. Abi?
Yes, Prof.
If 800 is one cycle length and I increase that same cycle length to 2000, it's going to take longer for one cycle length. But imagine if I reduce that 800 to 200, that means that it's shorter to take. Abi, you get shorter cycle length. Abi? So that means that if for a patient the cycle length is 200 beats is 200 milliseconds, that means that in a minute, how many beats will you have in a minute? One beat, 200 milliseconds. In 60 in 60 seconds, how many beats will you have? If you do that mathematics, you understand what I'm saying. Compared to one beat, 2000 milliseconds, how many beats will you have in a minute? Hope you understand that mathematics now.
It's a
Yes,
bit
Prof.
confusing for me now, but
Yeah,
I
okay.
think
No,
I'll find way
no,
around
no, the mathematics is not hard, Dr. Eugene.
it.
So I think the formula itself is supposed to be divided by 600. So in terms of cycle length, when they convert it. So, okay, Dr. Eugene, no problem. Let's do this. So we expect a patient to have you have your calculator there, right? You have your calculator there.
Yes, prof. Yes, prof.
Okay, so one beat is 800 milliseconds. You know we do that mathematics.
Yeah.
Okay, so in 60, so convert milliseconds to minutes. So I want to know how many beats will you have in a minute?
How many beats will you have in a minute if one beat
Yes.
is equal to is 800 milliseconds?
Yes.
Okay.
So how many milliseconds makes a minute?
That's supposed to be you're looking about six should be about 6,000.
6,000, Abi? Good.
Yeah.
So now, so one bit is 800 milliseconds, Abi? So how many bits will you have in 6,000? If it's one bit is 800 milliseconds. So how many bits will you have in 6,000? Yeah.
If you use the 6,000, it gives me 7.5. I think it's supposed to be 60,000, so it will give you
60,000, and that's
75.
what I'm saying,
Yeah.
60,000, yes.
So
So that's
75.
65.
Yeah.
Abi?
Yeah.
Okay, good. Now, let's say this same person, one bit is 2,000 milliseconds. So how many bits will you have in 60 seconds? In 60, so in that 60,000.
You said
One bit now.
22,000. That will give you 30 bits.
Can you see that now?
Yes.
So that means the longer the cycle length, milliseconds, the more the bradycardia, true or false?
Yes, please.
So can you now answer that? Can we now answer that question now?
Yes, please.
So that means the shorter. So let's now say one bit is 300 milliseconds. How many you have in 60,000?
If you're using 300 milliseconds, that gives you 200 bits.
Can you see now that? Is it now clear to you now?
Yes, please.
That the longer the duration, the more the bradycardia.
Yes, please.
The shorter the duration, the more the tachycardia.
Yeah.
Abi? Okay, so let's go back to the question now. So that I want to just make it as practical as possible so that when you're solving it, to be with confidence. No arguments. So can you now see this now? So is my screen clear now?
Yes, please.
So SVT, supraventricular tachycardia, are characterized. Can you see SVT tachycardia now? Are characterized by east ventricular interval that is shorter than that recorded during normal sinus reading. True or false? Dr. Eugene, yeah.
Hello. Hello.
Okay. Did you hear?
So we said we are going through the question. So we are on the
Okay.
B. Supraventricular tachycardia is characterized by his ventricular interval that is shorter than recorded during sinus rhythm. Prof, my problem here is the cycle length we are talking about. That is from the atrial wave from the high rise atrium lead to the next one that comes. But this is from his to ventricular. So that is where my confusion is, because the
wait.
cycle length does not apply to me from the explanation in this one, because this is
Relax.
his to ventricular.
I get you. See, I want you to get the basis of this thing very well. Remember when we are talking about even this same cycle length, BCL, it also entails whatever is happening at the east, Abi?
Okay.
Because from one P wave to the next P wave, things will have passed through the east, Abi. It contains east. Okay, let's go back to the slide now. It's not hard. I'm sorry. So let's go back to this slide. So you can see this is my slide showing, right? So this
Um,
BCA, you are talking about,
Oh,
does it
it's still the brown one that's showing.
it's a brown one that is
see
showing.
what I'm showing? No, I think it's network. Are you not seeing it now?
You may have to unshare this one. Okay, now it's gone off now.
Let me share screen. Okay. So can you see this
Yeah, I can see. We can see now.
BCL? You see this BCL?
Yes,
Does it entail your HV or not?
it includes it.
And they are now trying to tell you that when somebody is in tachycardia, the HV interval will be shorter than when he's in sinus reading. True or false?
That would be true.
So you can see that you cannot overthink the question. Because the same BCL you're talking about entails all the cycle lengths are merged inside it. You get that, sir?
Yes, sir.
Okay. So we can move on now. Is the brown was showing now?
Yes, please.
So option C. Dr. Okoye, option C.
Patients with sinus node dysfunction often have AV nodal conduction abnormalities. That's false.
Okoye. Yeah, sure. The question you ask yourself is that when somebody has SA node dysfunction, why is it that we just don't do single chamber pacemaker for them, putting atrial lead only? The reason is simple. It's because the same fibrosis that happen in the SA node will soon catch up with the what? AV node. I want you to get it very, very well. Most of the time when somebody has a SA node dysfunction, it's actually due to fibrosis of that SA node. The same pathophysiology of the damage that is happening in that SA node would catch up with the AV node. Okay. So sinus, so option D.
Sinus node recovery time is defined as the difference between the spontaneous sinus node cycle length prior to pacing and the duration of the first spontaneous sinus response after termination of pacing. That is true.
That's true. Sounds clear.
So what did we say about sinus node recovery time? Is this slide showing now?
Yeah, this is yes, this shows.
Yes, it is.
Okay. So what did we say about sinus node recovery time? Yeah? That the time interval between after you have suppressed the sinus node with pacing to the time you recovered the A wave, the SA node function, that is sinus node recovery time. Are you getting me, sir?
Yes.
The corrected sinus node recovery time is when you subtract that sinus node recovery time from the baseline. That is the corrected sinus. I gave us this stuff. That corrected sinus node. We first told you that there's baseline recovery time, right? Baseline cycle length, the normal rate at which the patient is normal rate. We now said, okay, we want to know how the sinus node can recover. Abi? So how can we push it out of function? Pace Abi faster with another catheter that can overdrive the SA node by pacing it faster in another tissue. Abi? So I can suppress the SA node. Abi? So when you suppress the SA node and you with pacing, then you abruptly stop, bam, and see it to recovery. So that means you are pacing. So that means you have your normal baseline. On this wave, you have your normal baseline. Patient has normal baseline, normal A wave, normal A wave. But you start pacing abruptly, faster than his normal SA node rate. Then you stop suddenly, right? You stop suddenly and you expect his SA node to recover, right? The time interval between when you stopped and when it recovers is the sinus node recovery time. Time interval, when I draw a caliper now between when I stopped pacing to when it recovered, that is sinus node what? Recovery time. Do we get that, sir? Is that clear, sir? That's why
Yes, sir, it's clear.
you can see, so you can see it in this figure. Do you see this bottom here where it tells you that the sinus node recovery time in bracket, the last S1 to first A1. Can you say last S1 to first A1 is what? 1175. That's the sinus node recovery time. From the last S1, the last time you paced, to the time it recovered its discharging. That time interval. It did not tell us any mathematics of subtracting something from something. Abi?
Yes, sir.
We now said that if you want to correct based on the baseline of the patient, just like you do for QT, corrected QT, you cannot do a corrected sinus node recovery time by subtracting the sinus node recovery time, which is 1175 here, Abi, from the baseline of the patient. The baseline of the patient is around 920, 930. So if you subtract it, then what you get is now the corrected sinus node recovery time. Can somebody help us subtract this from this? Does it equal to this? Oh yeah, has someone helped us?
So it's
245.
117.
Can you now see that? 1175 minus 930, what do you get?
and
It's
245.
245.
Can you now see? Do you now understand it now?
So they
Now,
use the
where you
920.
and so you can use the 920, whatever you get. You are just trying to show you the calculation now.
Yes, sir.
You get. So we are telling you that when you stopped pacing to when the SA node recovered, that time interval is the sinus node recovery. But if you want to correct for the baseline of the patient, all you need to do is what? Subtract that interval from the baseline. Before you started pacing, what's the baseline? 920 or 930. This is what you will get. Do we get it, sir? Dr.
Yes, sir, we'll
Eugene.
get it.
Yeah.
So can we now go back to the question now? You can see why I didn't want to rush this topic in the night. Okay. So let's take this option D again, Dr. Eugene. Yeah.
So the sinus node recovery time is defined as the difference between the spontaneous sinus node cycle length prior to pacing and the duration of first spontaneous sinus response after termination of pacing. So this will be the corrected one and not the sinus node recovery time.
So you're happy now that if you see this question in the exam, you will just chop them, right?
Yes, sir.
Yeah. So that's the purpose of this lecture, and that's why I asked for these questions. That's why I didn't want to rush it when you guys were solving it. You might not understand what it means. You get.
Yes, sir.
Okay. So we all know option E will be correct because accessory pathways are most likely to be left lateral. That's why they are difficult to ablate. So that is more of a prevalence. Okay, so which next question are we going to next?
So, Prof, that is the challenge here. So now the question was the except. So in this case, the except will be D.
Yes.
Okay.
Except is D.
Okay.
The except is D. All are true now.
Yeah.
We've started from the beginning now. Syncope, patients that have syncope and tachycardia, you can induce tachycardia in the lab now, Abi. And if they have SA node dysfunction, you can get that in the lab. AV node dysfunction, you can get that in the lab. Option A is correct now. True or false?
Yes, the confusion is at the time we solved it, Brownwood said the answer was B. So, but with your explanation now, it's clear. So that was what was confusing in my mind.
The thing is
But
straightforward.
it's D. Clear, obviously, it's D.
Oh, exactly. And that's why I brought out that they are lifted from the textbook. I was not the writer of the textbook. It's clear.
Yes.
Corrected sinus node recovery time is different from sinus node recovery time.
Yes, sir.
And yeah, mathematics are different.
Yes, sir.
You get? So rather than me just talking, that's why I said it's best I show you the graphs and the letters from the textbook. Hope it's
Thank
clear,
you.
sir.
It's very clear, sir. Very, very clear, sir. Thank you.
Okay, so what's the next question?
Just a second, please.
3. Okay, tell me so that I can.
366 was also part of it. So, what else?
So 366, have you?
Yeah,
This one.
366.
Okay, so it's not hard one. So let's sit down. Let's look at it. A sample tracing, Abi, from an electrophysiology study in a patient with narrow complex tachycardia. They've given us little differential, Abi. Like when they say narrow complex tachycardia, we can remove antidromic AVRT from it, Abi.
Yes, sir.
It's displayed. Then we can sometimes also try to eliminate VT. They've tried to eliminate some things for us. Now, it's displayed in the figure 3.8. So that means we can only make diagnosis by knowing figure 3.8. Abi? So we go to figure 3.8. Figure 3.8. Is my screen clear?
Yes, Prof.
Is anything blocking it? Nothing is blocking it. So should I widen my screen a little so that we can all see this? Is it widen enough? Is it clear now? Is it wide enough?
Yes, sir, it's clear.
Okay, so as usual, we have the surface ECG, have you? Lead 1, lead 2, lead 3, V1. So they just try to minimize a lot of things for us, have you? So they gave us RA catheter, have you? They gave us the East catheter, have you?
Yes,
They
sir.
gave us the catheter. Good. So the first thing you will notice here, so let's look at our waves, right? We have the RA, so the A waves are there, have you? Distinct. Now, I told us that, don't forget that when you're looking at A wave, how many waves are you supposed to expect to see?
In
One.
the right
Abi?
atrium, only one.
Yes. HRV, H1. So anytime you are seeing plenty things, you just try to decipher what do you think will be the plenty things. You are seeing something here, and you are seeing something here. Abi? But if
Yes,
you
sir.
continue to look down, you are seeing a single wave later. Abi?
Yes, sir.
Yes,
Okay.
sir.
So that means that initially something was happening. Then later they
This
left
is
things to happen by itself, right? So, and if you see the surface ECG, I'm sure when you see this on surface ECG, it already tells you something that they are pacing from somewhere. Abi,
Yes, sir.
they stopped pacing. You know, you guys asked why S1, S2. You cannot see your S1, S2, Abi. When you say S1, S2, they tell you that they are doing what?
Yeah, pacing.
Yeah, exactly. And they now put another S2 as a more premature. Abi, you can see if they were pacing at 500 milliseconds. Now we can be converting the rate. Now, since we know it's 60,000 divided by 500, you can tell us the rate at which they were pacing. Abi?
Yes, sir.
Then later, they reduce to 250.
Yeah.
You get? So 60,000 divided by 500 is what now? So that we can follow the.
120.
So they were
120.
pacing at 120 bits. Abi?
Yes, sir.
So now, at the S2, they reduce it to what rate now? 60,000 divided by 250.
So they went to 240.
240.
You can now understand why I was using at rate, why I was not using seconds that time.
Yeah.
Good. So that means you were sure that these first 3 times they were pacing. Abi? The first 3 bits they were pacing. So the others, they allowed the. And you know when they were pacing, they are trying to induce something, Abi. They are trying to induce tachycardia. Abi?
Yes, sir.
Good. So the question you now ask yourself is now, so they pacing spike. Now, how will you know where they are pacing from? It's very important. It depends on who appears first. We tell
Yes.
you they are pacing from. So most likely they were pacing from. So guess where do you think they were pacing from? From each of these TV catheters. Which of the catheters do you think they were pacing from?
Likely from the
Yes.
coronary sinus.
Exactly. I'm happy with we have finished this work. So they were pacing from the CS. So you can see our AHV, Abi, A, and we said CS, you should see two waves, Abi, A and V.
Yeah.
Abi, we talked about the locations that's in the atrioventricular groove. Abi,
Yes, sir.
good. So now, what happened? We could see AHV. Now, because we are pacing from the CS, well, it can have A faster than the, because that's the location we are pacing from, Abi. So you cannot say that earliest activation is from CS because that's where you started pacing from. Abi,
Yes, sir.
good. But if your earliest activation is still from the CS, when you stop pacing, then you know that there's a problem with the CS, Abi. But so when they stopped pacing, the question is, was the A earlier in the CS than the RAA? So let's look at something very simple and clear. You saw AHV, Abi?
Yes.
CS was faster than the RAA. Good. When they did the next one, AHV, CS was faster than the RA. Abi? So you did an extra S2, A. In fact, you did not see H and V. No be so?
Yeah.
Or did you? You didn't see H and V. It has already told you something. But that's not the end. When the rhythm now started, so that means there was a block somehow because you didn't
Yeah.
see H and V. Abi?
Yeah.
But remember we said we were pacing, not that it was the normal rhythm of the patient. Abi? So
Yes,
that
sir.
means it tested the AV nodal property. Abi?
Yeah.
There was a block. But something now happened, sir. So let's now look at this now. Can you find out the AHV together here? You saw here A H V.
Yeah.
This one. Can
You
you
had
say A H V in this one?
the H
No, you
before A.
cannot.
You beat your chest and say that everything AHV. I'm going somewhere. That's number one. No. So everything's crushed together. Abi? Yeah. When they were pacing, you were seeing A and V in CS. Abi? A and V in CS. Abi?
Yes, sir.
When they did S2, we know that it didn't conduct, so we didn't see the V. Abi?
Yeah.
But when the normal rhythm of the person started, where is the A and the V?
It's only the A.
They are in the same place.
They are in the same place. God bless you. Now, the CS is depolarizing at the same time when you're having RA at the same time.
Yeah.
You have crushed all the AHV into one. So what do you think will be your diagnosis?
AV and RT.
So can you see that this thing is not, you cannot understand now. It's nothing difficult. It's clear now. Abi? So does anyone have any question on this? So we can move on, Abi, because of our time. So we can go to the question now.
Sir, sorry,
Yes,
sir.
tell
Please,
me, tell
sir.
me.
Let me ask. Yes, sir.
Yes, let me widen it back.
In the his bundle one,
Hmm.
there are many spikes there actually. Like
Hmm.
in the whole that's the
This one,
first
Abi?
bit after
The
pacing
first
stop.
bit.
Yes, that one. Yes,
So
after the pacing stopped. Yes, that
yes.
no, not that one. The first, the where there is the arrow.
Okay, why they stop the pacing? Good. Okay.
Yes,
Yes.
yes, that one. Yes, yes.
Yes.
They are like there's one spike, there's another. It's like there are two or three spikes there. I don't know. That's I wanted to get
No
clarification.
problem. I get you. No problem. So you were pacing a patient, which one should be more narrower? When you were pacing or when you stopped pacing? Hello, did you get my question, sir?
Um,
When you are pacing
yes,
somebody faster, which interval should be
yes.
narrower? When you were pacing or when you
When you
stopped
are
pacing?
pacing should be narrower.
Abi, the wave should be more crushed together when you are pacing faster. Abi, interval should be shorter. Abi,
Yes, yes,
but when you stopped pacing,
yes.
compare now when you stopped
Okay,
pacing
okay,
to when you
okay,
were
okay,
pacing.
okay.
Which one shows you shorter interval?
Yes,
You now
I
understand
get
now.
now. I get. I understand. Yes, sir.
And then you can even see interval between A and V, which you can measure. But yeah, you cannot measure any A and V.
Yes,
Everything that's already merged into one.
yes, yes, yes. I understand it now.
God bless you, sir. So let me go back to the question now. $367 or 366. Abi 366 now. So a sample tracing from EP study in a patient with narrow complex tachycardia is displayed in figure 3. So what do you think is our diagnosis?
Typical slow, fast
See,
atrioventricular disorder.
You can see that this thing is straightforward. You understand? That's why I said we should not rush when we're treating it that time so that we can look at it together and understand. So where's the next question? Three. So this AV
367.
nodal, so this AV
367.
nodal reentrant tachycardia. Okay. So option C, that's AV nodal reentrant tachycardia. 367. Abi? That's the next, Abi?
Yes, please. 367.
Okay, good. So let's read this now. A 75-year-old woman presents following an episode of syncope. Abi? She was watching television with her husband when she suddenly lost consciousness and was unresponsive for approximately 20 seconds, right? So she awoke slightly confused, but otherwise felt well. Abi? So her past medical history is unremarkable. The baseline ECG demonstrates right bundle branch block and left anterior fascicular block. Abi? Now, an EP study was performed, and a panel from that procedure is shown in figure 3.9. So which of the following is the most appropriate recommendation? So that means before we know the recommendation, we should know what the study was. Abi? 3.9. So we'll go to 3.9. Abi? So 3.9 is 3.9. So let's study it very well. So I'll widen the screen again so that we can focus on that only. Okay? Sorry. Okay, good. So up I'm audible. So they gave us surface ECG, V1 and V5, right? They gave us distal east, Abi. They gave us east media. As I said, you can divide the east to, it's just the catheter you are dividing. East proximal, and they gave us RV. So one thing they didn't give us CS, Abi. They didn't give us RA, Abi. No problem. We'll use what they gave us. We expect that in the RV, there should only be one wave, Abi. And that's what we are seeing. Abi?
Yes, sir.
Good. We'll take it piece meat by piece meat. No problem. Okay, good. This is R wave, Abi. That is ventricular activation, Abi.
Yes,
So that
sir.
means if I'm looking at the east catheter, anything that is falling in line with the R wave will be the V, because I expect that in my east, I should expect A, H, V, right?
Yes, sir.
So starting from here, the question, so I will not get confused with the plenty wave. The one I understood is the R wave. If there was an RA wave, now I can use it to trace my A wave, Abi, on the east. But they didn't give me RA lead, Abi. They gave me RV lead. So that means the only thing I can use to decipher what's happening on my east is to look at my RV, Abi. So that means any wave I'm seeing on my RV is a V wave. True or false?
True.
So that means anything I now see on my east that is corresponding to my V wave is a V wave on my east catheter. And that will correspond to my QRS on the surface ECG. Is that clear, sir? Don't forget they said the patient has right bundle branch block, so you might have like an RSR pattern. Abi?
Yes, sir.
So that's not a P wave. It's not a P wave because I can see that it is on R wave. So it's likely the RSR pattern. Remember that we said a catheter in a chamber is only measuring activity in that chamber. It's different from a surface ECG that is summarizing the two chambers together. Abi?
Sir.
It's clear, Abi? So that means that on my surface ECG, if I trace my RV catheter to the surface ECG, this is my RV on the QRS complex. That means the next person on that same QRS should be my what? LV. Meaning that if I have an LV, if I have a LV catheter or a CS catheter, I will see it LV trace down. Do you get that?
Yeah.
Are we getting it?
Yes, sir.
What would have helped us better if they have given us an RA lead, then you can separate it very well. But they've given us RV lead. Let's use that RV lead to separate whatever we are seeing on our East catheter. Okay? So everything I'm seeing on the QRS correspond to what I'm seeing on this first QRS will correspond to what I'm seeing on the East catheter here. And that corresponds to what I'm seeing on my RV. Okay? So that I'll not model up the waves. That's why I'm saying so. Okay? So that's where this tracing started from. They started from the QRS. So I will expect this catheter to have AHV. Abi?
Yes,
So
sir.
let's go to the next cycle. So next cycle, I can clearly say that this wave I'm seeing on this distal is not related to the QRS. Abi? On the surface ECG. Is it related?
No, please.
So that means I can confidently say that it's not RV lead at all. And it's not related to the RV deflection because the next RV deflection is here. Abi?
Yes, sir.
So that means I can now see another spike after that. Then I can now see another same congregation of wave that I saw the first time from the beginning. I saw the same congregation of wave related to my RV wave. Abi?
Yes, sir.
And it's related to my QRS complex. Do you now get it now?
Yeah.
So that means all this disjointed wave we are saying is all RV. It's all ventricular, I mean. All ventricular V wave and related to the RV also. Are we getting that now?
Yeah.
So that means the guy I saw distinctly far away is A wave, H, then the V wave. Is it now clear now?
Yes, sir.
So we've traced this first two reading, Abi, two cycles.
Yeah.
So we can continue now, Abi. So let's
Yes,
continue
sir.
to. So I see this guy again that looks like my A wave in the first time of this A
Yeah.
wave. Abi, they look alike.
Yes, sir.
I see this spike. It resemble this spike, right?
Yes, sir.
Good. And I see that they are far away from the QRS. Abi?
Yes, sir.
Good. What should I expect next?
You expected a V wave, but there was no V.
Okay, good one. And that is also seeing this interval. There's already telling me something, Abi. Between this RV and this RV, it tells me that there's something missing here. Abi?
Yes, sir.
Good. Fantastic. So we continue. So the next thing is look at the next cycle now.
Yeah.
Sorry. You can see the distinct Abi
Yeah.
guy. It looks like the A wave very
A
well.
wave. Yeah.
We saw that spike. Abi? This
H.
spike.
Yeah.
Good. We saw the congregation of waves again
So
that
V.
might want to discomfit us. But we tell them that no, we are smarter than this because you are related to the QRS, you are related to the R wave. Abi?
Yes, sir.
And the cycle continues the same again. Hmm? AHV. So now we can comfortably say that we have analyzed the wave, right? So the question is, what is now happening? Abi? So that means I saw R wave, I saw AH, I saw HV that actually looks long.
Yeah.
Abi? I saw
Yes,
a
sir.
V. No problem. They didn't measure for us, so I can't start measuring from here. So I saw another A, I saw an H. Abi? That means I can tell you that AV node, AH is there. So there's AV node is functioning. Abi? Are we getting it, sir?
Yes, sir.
AH is there. That means the node, AV node, noda is active. But now, the R wave, you know, they are. Abi? So that
Yes.
means there's a problem with between H and V. So that would be what now? Is that nodal?
Is
Infranodal.
Okay, so it's clear now. Abi?
yeah.
So can we now go to the question now?
Yes, please.
Any question on this? So we can move on now, right? Okay, good. So let's move on. Let's go to the question 367. Abi? So the main story again is that 75-year-old woman, she had syncope. She was watching TV. Maybe they shouted on the TV, the Nigeria lost match. So she now collapsed. Okay. We're not sure if she has seizures, but she woke up well. Okay. No serious past medical history. So ECG, they've already told us that bundle branch block. Okay. Types anterior vascular block. That's why the trials was wide on the surface ECG. Okay. So now EP was performed. We have seen infranodal. So the question is, which of the following is the most appropriate recommendation? A, catheter ablation of the AV nodal reentrant and cardia. Eugene, you go ablate.
No, sir.
You know, go ablate. Eugene, go give beta blocker.
No, sir.
Maybe Okore could send for neurology consult, maybe na seizure. So let's move on. Then, will you go and do coronary angiogram to do PCI for this patient? Because EP has shown that the right coronary artery is blocked.
No, sir.
So we now know the answer now.
Yeah, pacemaker.
So this thing is now clear to us, Abi?
Yes, sir.
Okay. I'm happy it's clear. So
So,
which one is next?
Pops, I have a
Yes,
question, sir.
yes, ask me, Jama.
Because in that EP tracing, there's
Mm,
just one missed beat
mm,
or one missed hair.
mm,
Is it, and it's not like a steady, is it enough for a pacemaker implantation?
Okay, so Dr. Okore, what is Mobis type 2?
Okay, okay, okay,
Ah,
okay,
I know they are
okay.
demonstrating for you now. Is Mobis type 2 a high grade AV block or not?
It is a high grade and it's symptomatic.
Is it infranodal or not?
It is infranodal.
Where did we see the problem?
Infranodal.
Okay. Patient now
Yes.
collapse. Now said he should go and play football again.
And it's symptomatic.
Okay.
Yeah.
Okay.
It's
All
enough,
right.
sir. It's enough.
It's enough.
Thank
Okay.
you, sir.
So let's move on. Okay. All right. So, which question number? Which one is next? Dr. Jean, am I audible?
Yeah, the other prof, I'm checking. So the next one is
Yes, sir, we can hear you.
371.
371. I've passed that one. 370. 37. Okay, this is 371. Okay. So we read it again. A 60-year-old man presents with presyncope, right? And is found to have a wide complex tachycardia. So they've given us differential again. At a rate of what? 140 beats per minute. So an EP study is performed and tachycardia is induced, as shown in figure 3.1. So the mechanism of the tachycardia is, so before we talk about mechanism, let's first see this figure and know what type of tachycardia we are seeing. Abi? So figure 3.11. 3.11. Okay, good. So we can see this, Abi? So I widen in 3.11. I want to be sure. I want to be sure we are seeing it. So, are we ready? Good. Hope I'm audible, sir.
Yes, sir. Please, you're audible.
Okay, good. So they gave us surface ECG V1, V5, right?
Yes, sir.
They gave us, yeah?
Yes, sir. We
Hello?
can. You're audible, sir.
Okay, good. So they gave us surface ECG, V1 and V5. So they gave us HRA catheter, right? They gave us East distal, East proximal, and RV apex. So good. So we can trace some things very well. Abi? Good. They didn't tell us S1, S2, S3. That means they were not pacing. Abi? They didn't give us any sign that they were pacing because they didn't label S1, S2 or something. Abi? So that means that this is the rhythm of the patient. It's not a paced rhythm. Abi?
Yes, sir.
Good.
Yes, sir.
So let's start now. We have HRA, Abi? We should only see A wave, Abi?
Yes, sir.
So we see the
Yes.
first A wave, Abi? Again, oh, we see another A wave, Abi?
Yes, sir.
Again, oh, wait, we now see another A wave. Abi? Good. So let's go to RV wave so that we can tease out what is on the east catheter. You remember, Dr. June, I told you that it depends on how that east catheter is being positioned. Sometimes you may see the east, you may not see the east. Okay, good. So you see the R wave now, and we can see that this tall spike we are seeing is related to the R wave more than the A wave. Abi?
Yes, sir.
You can see that this is distal, this tall spike you are seeing, this tall deflection, is more related to this RV apex than the HRA. So you can see why HRA is very important in this kind of patients.
Yeah.
So that we can see the A wave far separate from the what? The V wave. So we can see a small deflection. You expect that HRA will come, it will come to this the lower atrium, Abi, before you see they didn't give us CS, but this is the concentric pattern you expect, Abi. A. But me and you know that's different from this big V wave. Are we getting it, sir?
Yes, sir.
Then I saw an A wave here. I saw an A wave here. I saw a V wave here. But the next time, did you see any A wave?
No.
Even on the distal east and proximal, did you see any A wave?
No, I
Did
don't.
you get that? But we saw another V wave. Then later again, we now saw an A wave, both on the distal and proximal east, and we saw their V wave deflection. Again, we didn't see again. So then we now saw our wave. Now that's number one. No? That's number one. Are we getting it, sir? Number
Yes.
two, sir. What's the distance between this A wave and this V wave? What is this distance between this A wave now and this next V wave? If truly that this A wave conducted to produce this V wave, what's the distance? See the relationship between this V wave and this A wave. Are we saying that it's going to depolarize? How far away will it depolarize another V wave? Looking at this distance in this last bit. So what does that tell us, sir?
It means the atrium is being depolarized after the His bundle has been depolarized and the ventricles also has been depolarized. It means is coming after and not before. Ideally, the HRA should be before his, but you are seeing it way after.
So the question I ask you, sir, is there a relationship between this A wave and this V wave?
You can't tell a clear relationship because it's not consistent.
And did you even see another one that has any relation? Do you think any A wave produced this V wave
No,
in this cycle? Is there any A wave that produced this V wave?
no,
In this cycle now, where my arrow is now, is there any A wave that produced this V wave?
no.
So what does that tell you? There is what?
There's
And I want us
dissociation.
to see I want us to see something again. I want us to see something again. Look at the timing. It's this guy to this guy. Do you know that if you look at this chart, if you look at the tracing well, you find that it's also the same time to the next one. Do you notice that?
So there's AV dissociation.
Exactly. Do you get that now? Look at the timing between this RV and this RV and this RV and this RV. Don't they look constant?
Yeah, they
Are
are.
you getting it now? Even this A wave looks constant from its long timing. Abi? Right? Are you getting it now, sir?
Yes, sir.
So there's atrioventricular what? Dissociation. So the question is, what are the possible differentials of the atrioventricular dissociation?
So a complete AV block can cause it. A ventricular tachycardia can cause it.
So let's now go up and answer the question. Is it clear to you? Does anyone have any question on this video? So we can go ahead, have you?
Yes, sir.
Okay, good. So let's go. That's 371, Abi?
Yeah, 371.
Let's just go. Sorry. So 371 says a 60-year-old man presents with pre-syncope, right? And is found to have a wide complex tachycardia at 140 beats per minute, Abi? An EP study is performed and tachycardia is induced as shown in figure 3.11. Abi? I want us to see very well. EP study is performed and tachycardia is induced at a rate of what? 140 beats per minute. So patient has wide complex tachycardia. So the question is, can you be talking about complete heart block at 140 beats per minute?
No.
Abi, are you getting something now?
Yes, sir.
And even the tachycardia was inducible. So in complete heart block, they induced tachycardia.
No.
You don't understand now.
Yeah.
So you now say the mechanism of this tachycardia is what? Atrioventricular reciprocating tachycardia utilizing an accessory pathway. AV nodal reentrant tachycardia with aberrant conduction. C. VT. D. D is what? Want to get to D. Atrial flutter with aberrant conduction. E. Sinus tachycardia. So what's your answer?
BT.
So you can see that it's straightforward.
Yeah.
Any question? So because what I'm saying is that when you're checking somebody for complete heart block, that's the same way it's also going to present. We are also checking patient for a VT. It's the same way it's going to present, but the difference is that it's going to be the rate. Do we get it, sir?
Yes, sir.
Okay. So you always see that VA conduction. So the origin of VA conduction came up from EP studies. I mean the VA dissociation, retroventricular dissociation, AV dissociation came from EP studies. Shall we get it?
Yes, sir.
So can we move on now? So which one is next?
380.
380. Three seven two. I thought there was 372.
Yes, there's 270.
Because I can see this just directly what we just after the one we just did. So, which of the following statement is correct regarding the electrophysiology abnormality depicted in 3.2? So, get again, which of the following statement is correct? So, they want to see. So, regarding what the figure in 3.12. So, that means first we have to discuss what is in 3.12. Then we can now talk about the possible answer to whatever question they want to ask. Okay, so let's look at. So, this is 3.12. I like to widen the screen so that we'll all see. There will be no argument. We all see the wave. So I want to separate some things. Okay, good. So we can see that they gave us a V, right? Surface ECG. They gave us RA. They gave us the EASE. Okay. So no problem. They didn't show us S1, S2, S3 to tell us about pacing. Abi? They didn't tell us that, right? Good. So we saw some calipers there in each of the QRS so that we won't mistake it for a wave. You can see those calipers, right? I guess they were trying to measure some things. So you won't think it's a wave in something. You can see there's no way the wave will reach the surface ECG up here. It can only mean that there's a caliper that they placed there. Abi, are we clear?
Yes, sir.
So that when we are now analyzing the wave, we will be sure of what we are seeing. We'll not get confused. So RA, you can see the wave. Abi,
Yes, sir.
single waves, right?
Single wave.
Good. So we can see RA wave, no problem. So EASE, they have helped us again to label the EASE. Most times they may not label it for us, but they've helped us. So we follow their label A, H, V. Abi? A, H, V. Like that. A, H, V, A, H, V, H. V. Okay, good. So before we look at the timing, let's look at AHV, AHV, Abi? That's the second cycle. Third cycle, AHV. Fourth cycle, AHV, Abi? Fifth cycle, AHV. Sixth cycle, AHV. Next, A, no H, no V. Abi, remember they didn't pace this patient, oh. Abi,
Yes.
they didn't pace. So we say that they are not testing AV node property because they are not pacing. So this is the natural AV node, how it is functioning. They were not inducing it. Abi,
Yes, sir.
good. Then later we now saw AHV. So we all know that there's a block. Abi,
Yes, sir.
we can't see the east. Neither can we say there is a V. So there's a problem between A and H.
Yeah.
So since there was no AH, there can't be HV. Abi,
Yes, sir.
if there's no pregnancy, there can't be delivery. So there's no H, there can't be V. No be so?
Yes, sir.
Good. So it's already telling us that it's a nodal problem, not is it okay, Dr. Eugene, nodal or infranodal?
It's nodal.
Because we can't find the H.
We can find the H, yeah.
So there won't be V. No problem. So let's go forward. They gave us information again.
Yeah.
AH here is 240. One beautiful thing is that they were only measuring the AH, they didn't measure HV for us. No problem. Next thing is that it is 280. Then later again, it came 290. Abi?
Yeah.
295. 295. Then jump to 325.
Broke.
And you can't find it again. Then later I started at 240. And I'm sure to now increase to 280 again. 290, 295, 295, 325. Then you drop again. So what's your diagnosis, Dr. Okoye?
Is a Weckenbach's AV block.
You have answered this. You can see that the thing no need plenty language. Abi? There's no need for plenty language here. So we can now, any question? Because I think this one no need plenty language. No question. The class has reduced.
No question, sir.
Okay. So Which of the following statements is correct regarding the electrophysiology abnormality depicted? A. It's associated with syncope and sudden death. B. When present with an inferior myocardial infarction, is an indication for temporary pacing. C. It typically reflects block at the level of AV node proximal to the east bundle. D. Aortic sinus massage typically abolish this abnormality. Is it SVT? So what's your answer?
C.
So it's clear, Abi?
C.
Yeah, so it's clear.
Yes, sir.
Great. So we can move on. What's next?
380.
380. Okay, good. So let's see this. So a 30-year-old woman presents because of what? Recurrent episodes of paroxysmal tachycardia with dyspnea and presyncope. So a maternal uncle died suddenly at the age of 27. So there's issue. And she's now 30. So an EP study is performed. So the intracardiac EGM at baseline, I want us to follow this now. They gave us an EGM at baseline and during what? Tachycardia, as shown in figure 3.15. So they gave us a baseline, figure A, and figure B, they have induced the tachycardia, right? So of the following choices, the most appropriate therapy is, so before we go to the therapy, let's even see the waves, all right? So that's 3.15. So this is 3.15. So we take it one by one. I like to see my screen very well. So this baseline, A, you got 3.15 A baseline, Abi. So we can see the surface ECG V1, V5, right? We see the HRA. They gave us a proximal ease. See, challenge here, they should have labeled the ease for us. CS 9 and 10, Abi. 7 and 8. 6 and 5. 4 and 3. 1 and 2. Abi. We'll have expected. So some people can be also deceive you and not label it. But with no proximal, we know distal. Then we know that the in-between. Abi. So we have the east distal, east proximal. Then we have the RV apex. Okay, good. So starting from the HRA, we can see HRA starts first, Abi.
Yes.
Then you can see that it's also, after it is your east catheter, Abi.
Yes, sir.
Then proximal CS, Abi. And the atrial activation goes that way, Abi. From the proximal to the distal CS1 and 2. From CS9 and 10 to CS1 and 2. Abi? It's clear now, Abi?
Yes, sir.
So if you follow the east now, we see the A wave. There's H, tiny H here, Abi, which is clearer in this one. Then we can see the V, Abi. Clear, right?
Yes, sir.
So this one looks normal to Abi. To me, did you see any problem? HRA is starting is close to the SA node. We expect east and the proximal CS should come next, Abi, to the eccentric pattern to the distal. So this eccentricity, it's coming from proximal to the distal CS, Abi.
Yes, sir.
Remember they said baseline, Abi. So most likely this patient will have narrow complex because proximal is goes straight to the distal. Then we have H, A, H, and V. The same thing here, Abi. We didn't notice any problem, right? We're just tracing it. Abi, HRA starting first. Then we have H, A, H, and V, right? Good. So the next side they induce tachycardia, Abi. Do you have any question in the image one? Any question in this baseline? Does anyone have any question? Before we go to
The only thing is with the CS lead, I don't see the ventricular component in the CS. Probably
yes.
maybe that
So
is not the lateral one.
good. So most likely the person that passed the CS lead, So it depends on, well, again, expertise of the person that is doing it. Okay. And sometimes if they also mute a wave, there's a way you'd be doing the procedure and we can turn off a wave if you don't want it to confuse you. You get? So there's a way I can do it on the stuff now. I can turn off the V wave even in the East catheter. You can mute. Those physiologist guys are very good at that. So, but let's just agree that they've labeled it CS and we are seeing the A wave. It's not likely to be a V wave because it's closer to the HRA and it's far away from the RV.
Yes.
You get? And if you see the East catheter, you can see that the East catheter has its own V wave, right? Closer to the RV wave. So there's no way that this CS catheter will be called V wave, right? Because they are far from each other. I hope you get it, Dr. Eugene.
Yes, sir.
Yes, we didn't see the V wave of the left ventricle, but we just keep up. It's what they gave us, so we have to use what is given to us. Okay. You enter the exam and tell them that the thing is not correct, that you should go and redo it. You use what you are given. Have you?
Yes, sir.
Okay, so let's go to the tachycardia. So let's notice something in this tachycardia. Patient has entered tachycardia, have you? So what did you notice? So from the starting point, you first see your HRA, have you?
Yeah.
See your distal CS1, CS, you should be CS3 and 4. Hmm? Are you getting it now?
Yes, sir.
See your V wave here. We have an A wave here because on the East catheter now, we can see A wave because it's corresponding to HRA. Abi?
Yes, sir.
We can see an E spike. Abi? Remember, it's in tachycardia now. Sometimes they induce tachycardia. Whatever they did, they've induced tachycardia. But they didn't tell us S1, S2. This is when it's in the tachycardia, but not on pacing. It's not being paced at this time. It's in tachycardia. I hope you
Yeah.
get it.
Yes, sir.
Good. So I want us to see something very well. So we can see the East catheter now. You can see it's close to this HA. Abi? We can see the East spike. Abi?
Yes, sir.
I see the V. Hmm? H again, close to the HRA, East spike, Abi? And the V. Abi? And it continues that like that, Abi? To the end. Abi?
Yes,
A,
sir.
H, V. A, H, V. A, H, V. A, H, V. So you notice that your East catheter HA is corresponding to your HRA. Abi?
Yes, sir.
But you will notice something, sir, that your CS distal, the guy closer to the sister, are activated first before your what? HRA.
Yeah. So it's
Two
an
of us.
eccentric part. Yeah. True.
So this is an eccentric. So what does that tell you?
Likely there's an accessory pathway.
No, it won't see with all the energy we don't put inside this thing. So yeah, I'm speaking colloquial language. I would expect you tell me the location
Oh,
of the
okay.
activity.
Okay. So
You
the
can't just
accessory
say that as
it's around likely you're looking at the C9 thereabouts.
Left lateral.
C7 to
left
C9.
lateral. Left lateral. Remember that proximal is 9 and 10, Abi? CS. Let me just go to that chart again so that we can get this. Apologies. Let me just go to this chart. So don't forget this. Can we see this screen?
Yeah.
So remember we said we label it 1, 2, 3, 4, Abi. They should
Yeah.
have labeled it for us, those
Yes,
guys.
sir.
But,
Yeah.
so you can see your proximal is 9 and 10, Abi.
Yes,
Yeah.
sir.
And the earliest you are seeing is around this distal end, Abi.
Yes, sir.
So it's telling
Oh,
you that this is the lateral, and that's the earliest activation coming before this guy. How can this one be determining the pace reading before SA node? It tells you that there's a something here, Abi.
yeah. Yeah.
So you can now see how they make diagnosis in EP.
Sorry,
Is it
but Prof, sorry, please. The distal,
Oh, okay.
the CS distal, I'm not really seeing any spike, Prof.
Yeah. So it depends on, as I said, how they position the catheter well and how it is touching the tissue. Remember, it's in the vein. So unlike others that are touching the wall, CS inside a vein, Abi,
Yes,
but
sir.
it's attracting whatever chamber is close to it. You get. So sometimes even when you are connecting it the ports, maybe you've seen it done before. You know, sometimes if you don't hook it well inside the ports, you won't see a wave or you'll be seeing artifacts. If you notice, when they are hooking those wires inside the EP ports. So many things can cause artifacts, many things can cause wave to be nullified. In fact, they can blank it out. You get, they can choose to blank it out if the electrode has problem or the port, the cable for the port has problem. So I won't just start battling why the wave is not there or not. You get, but let's just look at what they gave to us and what we can diagnose from what is given to us. So what given to us is that we can find out that somewhere farther away from the proximal CS is activating before the proximal CS. Are we getting it?
Yes, sir.
And they're activating the 7 before the HRA. And for you to know, proximal CS is supposed to be close to the HRA and supposed to be close to the East A wave. So you can see for the farther away CS to be activating before the East A wave tells you that there's a problem based on the activation. So this is where we talk about area of earliest activation. So the area of earliest activation is the distal end of the CS catheter. So these are around CS 3 and 4. If we don't use the 1 and 2 because we can't see the wave. But 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So around CS 3 and 4. Are we getting it, sir?
Yes, sir.
Does anyone have any question on this? Okay, so we can go to the question attached to it, right? That's 380, Abi. So a 30-year-old woman presents because of recurrent episode of paroxysmal tachycardia with dyspnea and syncope. A maternal uncle died suddenly at the age of 27 years. An EP study is performed. The intracardiac electrogram at baseline A and during tachycardia B, we've gone through it, is in figure 3.15. So of the following choices, the most appropriate therapy is A, ablation of the atrioventricular nodal slow pathway, ablation of an accessory pathway, implantation of an automatic cardiovascular defibrillator, direct cardioversion followed by long-term anticoagulation with warfarin. No further therapy is required. So, Dr. Okoye, what says that?
Yes, Prof. The answer is ablation of the ancestral pathway.
So you can see that all these things are straightforward. Dr. Ovunda,
Yes, sir.
is it clear, sir?
Very clear, sir.
So we all agree now.
Yes, sir.
Does anybody have any question? Okay. Dr. Rahim, I don't hear your voice. Okay. Any more questions, sir? Any more? Is there any other question apart from
Uh,
380?
it's 392. That's the last one.
392.
Yeah.
Does anyone have any question?
Outside this.
392. Abi?
Yes, please. 392.
So the electrophysiology study tracing in figure 3.20 was obtained from a 28-year-old man with palpitation, recurrent syncope, and structurally normal heart. Abi? So which of the following is the most appropriate therapy? And so before we talk about therapy, let's look at the study. 28-year-old, palpitation, syncope, and structurally normal heart. Okay. So 3.20. Okay, so this 3.20, right? So they gave us surface ECG 1, 2, 3, V1, Abi. So they gave us HRA, right? They gave us EASE catheter, either it's proximal EASE, whatever is, they give us EASE catheter. No CS, they gave us RV catheter, right? So we expect that the RV will record one wave, right? That's what we're saying, one wave in the RV, right? And it corresponds to the QRS, right? HRA should record one wave. So any other deflection will be far field deflection. It's not supposed to be there. So we won't get confused. Now, we see the EASE catheter, we see the A, we see the crushed H and V wave. We're going somewhere. Then you can see that the RV wave corresponds to the V wave, corresponds to the QRS. So the next, we also see an A, H, and V. Abi, this time around, you can measure AH and HV. But yeah, I'm not sure you can measure AH and HV. They look crushed together. But you can see that A is different from V. They are not depolarized at the same time. They are not on top of each other. So A is different from V. So this is not AV nodal reentrant tachycardia. But A of the E's so close to the H, so close to the V, compared to A separate from the H, separate from the V. The question we ask ourselves is that this duration that will be measured here, will it be the same duration that will be measured in this second cardiac cycle? Dr. Ovunda.
No, sir. No, sir.
Okay, good.
They are so close. It looks so close together in the first one and looks a bit different from the second one, sir.
You see that? So it's simply telling us that whatever we are seeing here is like they are very short if you're going to measure anything. Right? So another beautiful thing we should also know when we are doing EP studies that so that we don't get confused and get clogged up. You also have opportunity to look at the surface ECG. So if you look at the surface ECG, you can see your HRA corresponds to this P wave, right?
Yes, sir.
Then your V wave corresponds to this QRS, Abi?
Yes, sir.
This QRS looks wide. This P wave looks so closely meshed to this R wave. No problem. Let's go look at the next one. Next one, you see our A wave, well labeled for us, is attached to this P wave, Abi?
Yes, sir.
V wave, well labeled for us, is attached to this QRS, right?
Yes, sir.
And we can see that there's good distance between this P wave and this QRS.
Yes, sir.
And it looks narrow.
Yes, sir.
So can we say that it's the same distance? This PR interval distance for the second, is it the same distance for the first?
No, sir. No, sir.
So has that helped us to make a diagnosis?
Yes, sir.
Yes, sir.
So we now know our diagnosis, have we?
Yes, sir.
Because your AHV, everything looks very short. And we also, don't forget, we said AHV represents your PR interval.
Yes, sir.
Abi,
Yes, sir.
compared to the next one here.
Hmm.
They put it side by side so that you can see the difference. So I'm sure we now have a diagnosis in mind. Abi?
Yes, sir.
Okay, good. So let's look at the question. What we call ourselves? 392. Now, so the electrophysiology study tracing in figure 3.2 was obtained from a 28-year-old man with palpitations, recurrent syncope, and structurally normal heart. Which of the following is the most appropriate therapy? A. Atenolol. B. Verapamil. C. Pacemaker. D. Radiofrequency ablation.
We
E. Defibrillator implantation. So what's your diagnosis? What's your therapy? What's your
abolition.
answer? Yeah, straightforward. What's your diagnosis, sir?
Short PR
Okay,
suggested
so what?
accessory
Exactly.
practice.
You see, so you can see that this thing is straightforward. So all they needed to give to us was the CS catheter, where we can trace which one is the earliest activation and all that. But they just cover that one so that they can track your knowledge. So it's clear now, have you?
Yes, Prof.
Yeah, Prof. What would you say the diagnosis, Prof?
That's pre-excitation now.
Yes. Okay.
That's pre-excitation. And so what would be
Okay.
your
Okay.
treatment?
I agree. I agree.
And your treatment
Because
should
of
be
that,
appropriate.
but Prof, I want to find out why. I don't know, but from your expertise, why are they different? Because you should expect whatever. Because I'm seeing broad in like lead 2 in the first one. I'm seeing that the PRO interval is very small.
Mm.
Yes, I'm also seeing what looks like a delta wave in that lead
Yes,
2.
correct. Yes.
So, question is,
Delta wave.
why is it not in the other one? That's just what I'm asking.
On that this thing is straightforward now.
Yes.
Why do you have this delta wave? Is it not
No,
because
yeah, no, Prof, what I mean is this. Why is it? I was thinking that it's supposed to be consistent. Why is it showing in this first one and not showing here? Yes.
Ovunda, you have the answer, and I'm trying to bring the answer out.
Okay, sir.
Why do you think you have a delta wave and a short PR?
Hello, sir.
Am I audible, sir?
Yes. No, it's because of the
Yes,
accessory
we can
pathway,
hear
sir.
you, sir.
It's because the wave passed through the what? The conduction passed through the what?
Accessory pathway. Yes, sir. Yes, sir.
Now, good. Why does it look normal here?
Okay, now this one passes through the regular pathway.
Do you now understand now?
Yes, sir. Yes, sir. Wow.
And because somebody have one passing wire does not mean that you always be short PR. Abi?
Okay.
It can be concealed. Abi?
Okay, sir. Yes, sir.
Okay.
Yes,
Thank
sir.
you.
Thank you, sir.
All right. Any questions? I think that's the last. And it's almost 1 a.m. 1
Yes,
a.m. Nigerian
Prof.
time. 12 a.m. Ghanaian time. Thank you, everyone. We appreciate it. So I'll stop sharing here. I think that's the last.
I don't know what to say, but
No, so we would
on behalf of
plan
the
the
team,
space.
we
No
are
problem.
extremely
Okay.
grateful
No
to
problem.
Prof for
It's good.
when your Prof stays with you throughout this time, then you should know that you need to set up. Prof, we are very grateful.
No
We are
worries.
very, very grateful.
Thank you so
And
much.
we say thank you very much.
Thank you.
Thank you, Prof.
Wish everybody the best. God
Thank
bless
you,
everyone.
sir. Thank you so much,
Thank
sir.
you, sir.
Thank you.
Okay, Eugene, thank you too
Thank
for
you.
making it happen. Thank you.
Oh, I didn't do anything. No, Prof made it happen. No.
Thank you. Thank you.
Thank you. So God will continue tomorrow. It's already
All right.
morning in Nigeria, so good morning.
Morning.